So, okay, we'll start and we'll let people trickle in. So basically what I want to do, right? So I made this like obviously the PowerPoint's really long. I went through a lot of the primary literature and try to make things as simple as possible just by breaking it down by syndrome. Um, I feel like they teach bugs and drugs so poorly in medical school. You get your Staph aureus as a gram-positive cocci clusters that's coagulase positive, and you're like, oh, okay. And then like 5 months later, they teach you, okay, staph can cause this, this, and this, right? And then you're like, what am I supposed to do with this? I feel like the way medical school should be taught with bugs and drugs is it should all be patient centric, right? Patient comes in with cough, fever, pleuritic chest pain. What do I think as a physician, right? I'm leaning more towards pneumonia, maybe viral bronchitis, maybe we could talk about cardiac, GI, other pulmonary causes. And then you get a physician who goes, okay, if it's pneumonia, it's usually caused by boom, boom, boom. Here's my workup. Here's my management. Here's what I'm thinking. So that's kind of the way I structured this lecture. What I want to do with you guys is at the end, I just have like a crap ton of questions. So we'll go through as many of the questions as we can, so I can use the questions to kind of stimulate a conversation on that topic. And then I kind of separated them, like we'll have a couple lung, then a couple cardiac, then whatever. I just kind of put them in random order. When we're done with that system, I'm just going to run back up. I have like a summary slide just so I make sure I touch on everything. But the big thing I want you to get out of this is like, I put in doses. I don't care. Like, please don't memorize doses. That's just for you guys. What I want to get out of this is, okay, a patient has community-acquired pneumonia. What should our empiric therapy be before we know what the bug is, right? And then taking it one step further, why is that the empiric therapy, right? Because Sil and I were just talking. Anyone can go. I can pull anyone off the street and teach them for community-acquired pneumonia who's in the hospital. Let's start ceftriaxone and azithromycin, right? I could teach anyone that, and then they could take a test the next day, and they would be able to answer that right. But for you as a doctor, you have to understand why. And if we understand the why behind that empiric therapy, I no longer have to memorize it. Okay. And so we'll go over that. So really, like, what I would like you guys to get out of this is like broad strokes. Okay. Patient comes in with boom, boom, boom. Here's what I'd like to start, and here's the why. We can talk about like a lot of like the really cool diseases, like, your malaria, babesia, tularemia, stuff like that. But those are going to be lower yield. So we'll probably stick with like these high yield syndromes. And then if you want, I can go over some of those at the end. And then I have like the first couple slides are really going to be like how do you think through like an infectious disease workup? Because there's very specific things that you need to consider when you're working up a patient for any kind of infectious syndrome. And the big things that a lot of people miss are really hammering in on your travel history. And that's not just saying, hey, did you go on any trips recently? And the patient goes, yeah, I went to like Thailand last week. Then you're like, oh shit, that just opened up like a huge box of worms, right? Like if the patient went to Thailand and now they've got pneumonia, you're like, oh shit, is this mediolosis, right? Is this like a really bad Burkholderia infection? But then what I need to do is you need to break it down even further. Like, can you give me a day by day? Like, what did you do, right? Did you go spelunking in a cave? Did you go water rafting, right? Like those are important things that you need to get out of your patient. So it's travel history. It's what do you like doing for fun, like occupation. Do you have any pets? Did your pet scratch you? Have you been around any wild animals recently? Any chance they could have scratched you or bit you? Any ticks, fleas, mosquitoes, things like that. Okay. And I'll just give you an example on the ID rotation. We had a guy, he got transferred from Wausau. He ended up having blastomycosis pneumonia so severe that they had to ventilate him and then put him on ECMO. He had to come here for ECMO. And for like if you guys don't know what ECMO is, it's basically a machine that it's your heart and your lungs for you. So it's like as bad as you can get. And this guy, like, I feel so bad for him because one, he's living in central Wisconsin, which is like hyper endemic for blasto. Like when you think about your blasto and histo, like central Wisconsin is like where they both intersect. Like that has to be on your differential. And so this guy came in like early February to the urgent care with cough, fever, pleuritic chest pain, blah, blah, blah. They did a chest x-ray. They saw like multifocal pneumonia, sent him home on ceftonir and doxycycline. He took that for 3 days. Then he went to the ED because he wasn't feeling better. And so they had this. they ended up doing a sputum sample, and it came out with gram-positive cocci and clusters, and then it also came out with gram-negative rods. And they were like, okay, let's treat this guy with vancomycin and cefepime. And we'll talk about why that was a poor decision to begin with. Doesn't matter. They kept him in the ED or hospitalized for like 3 days. They said he was getting better. What that means, I don't know. They ended up sending him home then on augmented and doxycycline. So he had now seen two separate providers and had even been hospitalized for 3 days. They sent him home. He goes home on augmented and doxycycline, takes that for 3 more days, comes back to the ED and is like on death's door. He's like, I'm still not doing good. He was so sick, they had to ventilate him. They finally did a bronchoscopy. And what did they see on the bronchoscopy if it's blasto? Correct. They finally saw a broad-based budding, and they started him on Ampho B. He was on the ventilator, and then they're like, oh shit, he's going to need ECMO, send him down to Freighter. So at this point, right, it's been almost 2 weeks that this guy went where he failed multiple treatments for community-acquired pneumonia, and they treated him for freaking MRSA and GNR pneumonia, which is, we'll talk about why that was like a stupid decision. But it's like at some point, you need to take a step back. You're like, we're in central Wisconsin. Did we ever consider blasto? No, and they didn't do it until the BAL. And so the first thing I did when this guy, we finally got him off the ventilator, we finally got him off ECMO, and he could talk to me. I'm like, what do you do for work? He's like, oh, I work in like agriculture. And I'm like, okay, are you around like soil and water? He's like, yeah, every day. Like I'm around the soil. I'm like, well, all I would have taken was that. And then they would have had a suspicion of blasto. They're in the right spot. They could have easily done some sort of workup for blasto, right? And they could have prevented him going on ECMO. So that was like an aside, and we'll talk about treatment failure for pneumonia when we do the pneumonia cases. All right, we're good on that. So I've got an open-ended case on 14. So I'm going to be the patient. This will help like the students who haven't done what's the clinical reasoning exam or whatever. It'll help you guys kind of work through history taking, physical exams, stuff like that. And then for the people who have taken it, it will help you get ready for your sub-Is. So all you know, I'm gonna pretend to be I'll speak for the patient. All you know is it's a 28-year-old male. He's got 1 week history of cough and fever. There are his vitals. That's all you get to know. So you guys ask as many questions as you want. Obviously, we don't have all day, so be specific with your questions, and then I'll let you decide which physical exams you want and which labs, imaging, etc. you want. Here, I sent it. Huh? Right now, a little bit of vomiting. I vomited yesterday, and then I've had some diarrhea for the last couple days. And then just the usual, I have fever, a little bit of fatigue. My muscles hurt. Me? This guy lives in Milwaukee. We'll say it's at Freighter. Well, not at Freighter. He lives in Milwaukee. Huh? No, he doesn't live in a dorm. He lives in an apartment off State Street. Vomit? I don't know. It looked kind of like the food I ate. No, it wasn't red or anything or green. I have been coughing up some phlegm. I don't know. It looks green to me. No one's sick around me. I did travel recently. About a week ago, I traveled to a resort in Mexico with my family. I had bottled water, and then whatever the resort was giving me, but the resort was really clean. Good question. Spent a lot of time at like the pools and the hot tubs on the resort. We did spend one day where we went zip lining. That was really fun. I mean, we made sure we followed all the rules. They told us we had to wear like long sleeves and long pants, and we had to use a lot of like mosquito repellent. So we did that, and then we also spent one day where we kind of just went out and explored some of the city. But we had a tour guide that made sure we stayed kind of on the normal paths and everything. No medical history. This guy's really healthy. Not that I know of, and none of my family that they know of. The last couple of days it's been pretty bad, like probably like 4 or 5 times each day. Watery, no blood in it. Good question. No one else in my apartment. Although I'll tell you, my roommate told me that yesterday when I was talking to him, he thought I was speaking a little bit slow, and maybe I wasn't making as much sense, and that's kind of what eventually got me to come in this morning. Not that much. I definitely feel dehydrated. Trying to ask me if I've seen any other doctors. Yeah, I did. I went to urgent care a couple days ago, and they thought that I might have had pneumonia. So they treated me with amoxicillin. So I took amoxicillin for 3 days. I still wasn't getting better, and that's why I'm here. Um, I don't know. Can you look at my chart? No. Yeah. I think they said all my labs look pretty normal. And then the imaging, they said there was something in my lungs that they thought it was pneumonia. So they gave me the amoxicillin. That's all I know. Nope. Usually don't for outpatient pneumonia. Oh, good question. I have been taking the amoxicillin as they prescribed it. Okay, you guys got enough history? Okay, how would you sum up if you had to one liner? What's going on here? I would say healthy young male presenting with treatment failure pneumonia post travel to Mexico. I think that's a fair assessment, right? At this point, like when do you call it treatment failure pneumonia? It's like up in the air, but 3 days on amoxicillin, still not any. He's still getting. His clinical history is still deteriorating. Pretty concerning. And then on top of the pneumonia, we also hear some diarrhea and then maybe some altered mental status. I don't know. We'd have to get some more history on that, right? We have his labs. We know, or we have his vitals. We know he's got a temperature. We know his SpO2 is a little bit low. He's a little tachypnic. And his blood pressure is stable. Okay. So what we'll start with physical exam. What physical exams would we want on this guy? What? Lungs. Okay, on lungs, on the left lower border, or sorry, left lower lobe, you hear some crackles. That's the only abnormality. You do some dullness you do percussion and you feel some dullness there as well. Abdominal exam, just some mild tenderness, kind of diffusely. No rigidity, no guarding, no peritoneal signs. Cardiovascular, normal. Heart rate is normal rhythm, no murmurs, rubs, gallops, nothing abnormal there. Definitely some dry mucous membranes. Eyes, we'll say maybe he's got some some conjunctival pallor bilaterally. The rest unremarkable. Skin, no acute findings on his skin, no rashes or anything. No edema. Does anyone want to do a neuro exam on this guy that might have altered mental status? Okay. Neuro exam is normal. We'll say he's A&O times 4 today. Anything strike you on these vitals when you walk in the door? Mm-hmm. What about is there anything about the relationship between his temperature and his heart rate that might kind of raise an eyebrow? Huh? He might qualify for sepsis, yeah, if you use like the SIRS criteria, but correct, right? So this is relative bradycardia or pulse temperature dissociation, right? So that might raise an eyebrow when I'm considering certain causes of maybe pneumonia or what else this guy has going on, right? So now, like, just based off of physical exam and off of his vitals, right? I mean, I'm leaning more towards a pulmonary cause, but he's got this diarrhea going on. And so when I think about a patient who's a traveler, like traveler with a returning traveler with a fever, there's so many things that come to mind. But it really depends on where they are. But a couple things that like, what are some things that cause relative bradycardia that come to mind? Anyone? Huh? Well, heart block, yeah. So the big one that this is not what this guy has, but have you guys heard of Salmonella having relative bradycardia? Like that's like the classic example. Salmonella typhi. This guy would be a lot more sick with a lot more GI complaints if he had Salmonella. But that's something you got to consider from a patient traveling who's got abdominal findings, diarrhea, and relative bradycardia. That's not what this guy has. He's got a different cause of relative bradycardia. Okay, what labs do you want? Okay, chest X-ray shows a left lower lobe opacity. CBC, it shows his white blood cell count, we'll say, is just slightly elevated. It's at 11. But then when we get a differential, his lymphocytes are quite low. The absolute lymphocytes are low. So we'll call them as lymphopenic with leukocytosis. The neutrophils are elevated. Yeah. But not there. We'll say there aren't any bands. So neutrophils are elevated. So he's got some neutrophilia and he's got some lymphopenia with an overall mild, very mild leukocytosis. His hemoglobin's low. We'll say it's 9.7. His MCV is 90. And then his platelets are 500. That's his CBC. All right. What do you say? You said CMP? CMP, we see slightly elevated BUN and creatinine. Okay, we'll say the ratio between the two is 25-1. Both are above his baseline when we look at his past data. His ALT and AST are both mildly elevated. We'll say they're both in the low 100s. ALP is normal. T-Billy is normal. Let's see. His sodium is 125. His potassium is 4.5. Chloride and bicarb are both within normal limits. And blood glucose, we'll say, is normal. We can do a sputum culture. Okay, so we'll do. What are you looking for in the urine antigen? Which Legionella? Which Legionella? Which Legion? Is there only one? So Legionella pneumophilia, there are multiple serotypes. The urine antigen only tests for serotype 1. So are you okay with that? Yes, you are. You guys are all. This is the one of the best tests we got. So we'll send the urine antigen. But again, you are the physician. You have to understand the limitations of every test you order. If you have a strong suspicion of Legionella or Legionnaire's disease, right? If the urine antigen comes back negative, are you just gonna be like, this isn't Legionnaire's disease? I'm not gonna treat it, right? So you have to understand, right? So we can send the urine antigen. I agree. Let's send a sputum culture. And if you're looking for Legionella, what do you have to tell the lab? We could do a PCR as hit or miss with Legionnaires. So for Legionella, what's the problem with Legionella? Correct, right? It's an intracellular pathogen. You got to tell the lab, I need to put it on L-cysteine agar, right? And sputum culture is going to take 3 to 5 days. And we can tell the lab, hey, run it. We'll send the urine antigen. What else do we want? Anything? Huh? We do a stool culture. Not going to show anything, but that's okay. Not in this guy. I wouldn't if I don't have a concern for infectious diarrhea. I think our workup's pretty fair. We could consider getting a blood culture. Is that going to show anything? Probably not. So I agree, right? So this sounds a lot like Legionnaire's disease. Okay. Why is this Legionnaire's disease? Break it down for me. Mm-hmm. So everyone heard that? So just so I can make sure the people on the recording here. Legionnaire's disease, Legionella, right? Legionella pneumophilia, serogroup 1 is the most common cause of Legionnaire's disease. There's multiple serotypes. The reason we have the urine antigen for serotype 1 is it's the most prominent cause. Legionnaire's disease, where actually Legionella can cause two different types of diseases. Pontiac fever, which is just usually a low-grade fever, maybe a little cough. And then Legionnaire's disease is what will send the patient to the hospital. Legionnaire's disease, we classically see relative bradycardia. That's what's going on with this patient. It's one of the causes of relative bradycardia. We see transaminitis. We can see an elevated CK. We can see hyponatremia, and then we can see diarrhea, and then obviously your pulmonary symptoms. Legionella can cause any type of pneumonia, okay? So it can cause a lobar opacity. It can also cause an atypical infiltrate, right? So there's no like, I can't just look at the chest x-ray and be like, yep, that's Legionella, right? It's got to be a clinical syndrome. So it's usually spread by water, okay? It can either be aerosolized or via water. You classically see, right, this guy was hanging out at the pool, the hot tub, that's likely where he got it. You could see outbreaks in hospitals, nursing home settings where the water got contaminated with Legionella. It's an intracellular pathogen, okay? So you have to be very careful about how you treat it, right? Why was the treatment approach wrong the first time? We gave him amoxicillin. Was that an appropriate antibiotic? No, right? I agree with if the patient shows up to an outpatient hospital or like an urgent care and he's not like overtly sick and you're like community acquired pneumonia, my two major options, what are my two major options for community acquired outpatient pneumonia in a patient without comorbidity? Well, yeah, that would be one of your causes. Yeah, so what's the problem with macrolides now? Yeah, so strep pneumo in most places in America is going to be over like 25% resistant. We don't like using azethro by itself. I agree, though. It's still listed in most guidelines. It shouldn't be. So right now, I got a patient who's got community-acquired outpatient pneumonia. We're going to treat him outpatient. We'll talk about how we make that decision in a second. They've got outpatient pneumonia, no comorbidities, amoxicillin or doxycycline, okay? Amoxicillin or doxycycline, either would be good. It really just depends on your kind of vibe. And in that patient, relatively young, healthy, amox is probably fine, right? But he had treatment failure pneumonia, and so now we have to be like, what do you guys think about when you have someone, we treat him with an appropriate antibiotic, right? But he's not getting better. What do you think of? I don't mean like bugs, like what's your overall framework? Correct. Biggest question I always ask myself is, am I treated like, is this pneumonia, right? Could this be bronchiectasis? Could it be other structural lung disease? Could it be cancer? Could it be anything else, right? That could be going on in the lungs, sarcoidosis, XYZ, right? So is it pneumonia? I always ask that. Am I treating the right bug is the next question you should ask, right? And in this case, we weren't, right? We were treating him for typical causes of community-acquired pneumonia. Legionnaire's disease is an atypical cause of pneumonia, right? So we're about to do a practice question on it, but since we're on the topic, what are my typical causes of pneumonia? Mm-hmm. Community-acquired pneumonia? I hope not. That's okay. Nope. So that's an atypical. Haemophilus influenza. Okay. So my three major causes of bacterial community-acquired pneumonia: strep pneumo, Haemophilus influenza, Moraxella catarrhis. And then obviously all my viral causes, right? Antibiotics are not going to work against virals. Viral pneumonia, you classically see your bilateral infiltrates. Patients usually aren't as sick. COVID and the flu can absolutely cause very severe forms of pneumonia. So my amoxicillin or doxycycline will work great against really all of those if this was an outpatient. And really, if I'm talking about an outpatient community-acquired pneumonia without comorbidities, I'm probably leaning less towards like a Moraxella and Haemophilus. Like you got to be pretty sick with structural lung disease to be colonized with those bad boys. So the most common cause of bacterial community-acquired pneumonia is strep pneumo, right? And amoxicillin will cover that. Doxy is maybe not the best choice, but it'll work. But Legionella is an intracellular pathogen. Amoxicillin that we gave this guy is a beta-lactam. How do beta-lactams work? Correct, right? So it blocks your penicillin binding protein, okay? Legionella is inside is usually it lives within macrophages, your lysosomes, things along those lines. The amoxicillin ain't going to do shit, right? So that's when we got to take a step back and we're like, are we actually dealing with a atypical type of pneumonia here where I need to use a antibiotic that'll actually work on intracellular pathogens, okay? So what are my three major intracellular pathogens of pneumonia, bacterial pneumonia? We've talked about one, Legionella. No, not salmonella. No, yeah. So Chlamydophila, they changed the name, Chlamydophila now. But yes, chlamydia. It used to be called chlamydia pneumonia. They changed it to Chlamydophila to stop it because everyone got it confused with the genital tract. Chlamydophila, Legionella. What's the last one? You guys have already said it. Mycoplasma, right? And then we can get into the weeds and be like, all right, is this patient a vet or are they a farmer? Did they just touch like the amniotic fluid of some of their animals? Is this Coxiella? Did they just get bit by a rabbit? Is this tularemia? We can go down all those routes. But your three major atypicals are Mycoplasma pneumonia, Legionella, and then our Chlamydophila. And so all those, really, the gold standards are going to be doxycycline or levofloxacin. We can use azithromycin, but azithromycin, again, we're gaining a lot of resistance to it. But really, any of those three drugs should be a reasonable approach. Legionella, we really like more azithromycin or levofloxacin. Doxy isn't the best, but it's really hit or miss. So taking a step back, your straight up community-acquired bacterial pneumonia, we're going to do outpatient, no comorbidities, amox or doxycycline. That'll work for strep pneumo, Haemophilus, Moraxella. If we have an atypical form, we have to use an antibiotic that works intracellularly. And so those are going to be things like azithromycin, doxycycline, and levofloxacin. That makes sense? We're all good. For antibiotics, doxy, azithro, or levofloxacin. Okay. When you think about like I have at the beginning of the PowerPoint, I go into all the antibiotics and antifungals, so read about those. When you think about your fluoroquinolones, there's three major ones. There's levofloxacin, ciprofloxacin, and moxifloxacin. It is, yeah, do you have a question? Oh. Yeah, no, I've never looked at it, but when I think about it, right, levofloxacin is L for lung, right? That's not actually, but levofloxacin is great for respiratory pathogens. Ciprofloxacin is great for intra-abdominal pathogens, and moxifloxacin has added anaerobic coverage, so it's great for whenever I'm concerned for an anaerobic infection. Okay, it is a lot more complex than that. There's a lot of intertwined, but like for a second, third year medical student, like that would be like to the level if you're taking a board exam or you're thinking about a patient. Levofloxacin lung, right? If you we're about to talk about community-acquired pneumonia inpatient, you probably have seen in the guidelines you could use levofloxacin monotherapy. That's why, because it's got activity against strep pneumo in the lungs. Cipro, again, great for a lot of my intra-abdominal pathogens. We'll talk about that coming up. And then moxifloxacin, again, has the anaerobic coverage. We're good on that. So this was a case of Legionella pneumophilia. We're good? Okay. So we'll go all the way down to the bottom because I will let you guys read all the fun stuff on your own. And we'll go through the questions. So I'm on slide 117. I wanted to just highlight before we start, because I don't have a question on this, and I don't know if I actually put it in the PowerPoint. What do you know about influenza and then secondary bacterial pneumonia? What's the pathophys? We'll start there. Mm-hmm. Yep. So influenza does a really good job at destroying your mucociliary escalator. So we can't remove some of these pathogens that are colonizing our lungs or living in the lungs. So basically influenza comes in, it breaks down all of my barriers, and it just allows secondary seeding of bacteria, right? So my classic vignette or my classic patient, hey, they just had a week of fever, cough, myalgias, diarrhea, right? Your classic flu. Maybe they even went to urgent care. They have a documented positive influenza A, and now they're presenting to the ED with like severe pneumonia type symptoms. That's when you think about secondary bacterial infection. And what are the two most common causes of secondary bacterial infection after the flu? Correct. Staph aureus and strep pneumo. Those are the ones you need to know, okay, for your board exam and for real life, okay? So that'll be the only instance where I'm really thinking about Staph aureus as a cause of community-acquired pneumonia. It's like hit or miss. Would you consider this community-acquired pneumonia because they were already predisposed? I don't know. I guess they got pneumonia out in the community, but we'll talk about that in a second. Does that make sense to everyone? Okay. All right. So on 117, we have a 68-year-old woman with a history of type 2 diabetes, COPD. They present to the ED with 3-day history of fever, productive cough, purulent sputum, and progressive dyspnea. She reports increased confusion over the past 24 hours, as noted by her daughter. She has not traveled and recently and lives at home. There's her vitals and the physical exam. There's her labs. There's her imaging. So I want you to think about what should we do for this patient. And all of my questions are open-ended because I don't do the multiple choice BS. I want you guys to actually work on your clinical management skills. So I really, basically, when I approach this is what is the disposition for my patient? Should I have them outpatient, inpatient, ICU? And then what's my diagnostic workup and first line management? So please talk with each other, take a minute or two, think through this.
Okay. Okay, so after we do airway. Well, that's, yeah, airway phrasing. Oh, I mean.
So if we're admitting her and this one we just go.
Yeah.
So that.
Yeah. Do we need to order any other tests? Yeah.
Oh, yeah.
Or like it. I think she should. Yeah, so like, I would just try to get that over for this.
That's right.
There's every time.
Just because, well, yeah.
So just to summarize, we got litter, as you can, I use, no. Well, hopefully.
What?
Oh.
Well, if we're giving it IV though, if we're giving IV, it's like set.
Let's talk about it so we can keep moving. So the big thing with this should go for the rest of your life, but especially infectious disease. When I'm dealing with a potential infectious disease problem, there are two things I always have to do. I need to define who my host is, and I need to define what my clinical syndrome is. If I do both of those things, there is an overlap, and we can easily decide what the next step is, right? You obviously have to know your guidelines. You have to have some clinical management. But if I can go, okay, this is a patient with X, Y, or Z, and they have X, Y, or Z, where's the interlap, and then how do I treat them, right? So my patient right now, she has some comorbidities, right? Type 2 diabetes, COPD. She's ripe for getting really bad infections, right? And then how do we define this clinical syndrome? Yeah, I would call it severe community-acquired pneumonia, probably, right? So then when I've got my patient, I've got my syndrome, we're talking community-acquired pneumonia at this point, I should know exactly how I want to treat her, right? So what are we thinking? Where do we want to admit this patient, right? You're in the ED, we're calling the AMO, and we say this patient needs to go I would agree. The ICU. Why ICU? I heard it. I heard it. I was waiting for you to say it. So what's her curve 65 score? Yep. So for you guys, the curb 65 is a great if you're in the emergency department or you're taking a board exam, do the curb 65. The curb 65, you have confusion, urea over 20. I've seen it 19 or 20, it really doesn't matter. Urea over 20, the respiratory rate over usually 24 is what you'll see in the literature. The blood pressure is going to be systolic less than 90 or diastolic less than 60, and then the age over 65. You get a point for each of them. All right. Usually, if the patient has a 1, outpatient. If they get to a 2, that's when we start to consider maybe they need inpatient, especially if they have comorbidities. A 3, definitely inpatient. And really a 4 or 5, they're going to the ICU. And it's not as like clean cut. I can't just be like, oh, they've got a 3, they're going to the floor, right? You got to use like some management or like some thinking here. On a board exam, they're going to give you one end of the spectrum or the other. Like this patient is clearly sick. They're altered mentally. They've already got some hypovolemia, right? We see an elevated BUN. They're pretty tachypnic. They're having a hard time breathing. Like this is a patient, especially with comorbidities, I'd send them to the ICU. In real life, if you have the time, you should use the pneumonia severity index. It's a huge number of labs that you put in, but it's something you can easily just find on MD Calc, and it will give you a much more precise answer. Obviously, you're not going to memorize all that stuff for a board exam, nor are you going to have all those labs. So the curb 65 is a great first option. Then I heard over here, right, probably going to have to put her on some sort of oxygen, right, whether it be a nasal cannula, non-invasive positive pressure, or potentially intubation, right, if this patient is not able to protect their airway, right? I don't need you guys to tell me which one, right? Again, on a board exam, they're going to make it very obvious, right? They're going to like literally like spoon feed you like this patient can't protect their airway, or maybe they're just having an acute exacerbation of COPD and you just got to put some non-invasive positive pressure in them. So I definitely agree. Let's get her some oxygen. All right, we're going to admit her to the ICU. Any other labs we need to get her? Anything else? Yeah. So the guidelines will say for severe community-acquired pneumonia, we should try to get a blood culture and we should try to get a sputum culture if possible. Okay. Like we kind of talked about for like outpatient pneumonia, you're not going to get a blood culture and you're not going to get a sputum culture. And really, if my patient is inpatient and on the floor, most of the time, I mean, we're going to try to get a sputum culture. Most of the time, we're probably not going to be able to. And it's really not going to change our management. But for someone who's sick enough to get them a ticket to the ICU, we should try to get a blood culture and a sputum culture. And do we want to do that before or after antibiotics? Absolutely. We always want to try to get it before, because even if you give the antibiotics and you try to get the sputum and blood culture just shortly after, it still reduces your yield on that, right? So as long as the patient's not crashing and they don't need antibiotics ASAP, try to get the sputum and then the blood culture before. All right. We see the procal is elevated, right? Procal is kind of a hot topic, but if it's above 0.25, that's usually when we think about bacterial causes. Right now, like the guidelines are saying, we should use procal and we should watch its trend, and that'll tell us when we can stop antibiotics. We don't really have great data on using it to say, yeah, this patient absolutely needs antibiotics. So we're admitting him to the ICU. We're starting oxygen of some sort, whether it be ventilation or not. We're going to get blood and sputum cultures. And now what else should we do for this patient? Antibiotics. What do you want to start? Okay. Got it? Amoxicillin. So I hear ceftriaxone. I hear amoxicillin. Do we agree, disagree? Okay. And see, this is where you will see a lot of doctors will freaking put the patient on like vancomycin and cefepime, and you're like, what are you doing? Okay. So just because like the patient looks really sick, like you take a step back and you're like, no, what are the causes of community-acquired pneumonia? Yes. Not so what of the three, we've heard ceftriaxone, amoxicillin, and amoxicillin, not unison either. We'll talk about unison in a second. Huh? Because we're doing it IV, yeah. So first off, yeah, amox is an oral drug, right? Ampicillin would be the equivalent to amoxicillin IV. What are my drugs for community acquired pneumonia inpatient? Ceftriaxone, and we got to cover my atypicals. So either azithromycin or doxycycline. Okay. So let's take a step back. Community acquired pneumonia inpatient. We do usually a third generation cephalosporin. The guidelines will say beta lactam, right? The beta lactam that is most commonly used is ceftriaxone, okay, because it's got great gram positive and gram negative coverage for what we want to cover. We'll talk about what it doesn't cover in a second. So it's usually ceftriaxone, okay? Then we got to cover my atypicals, right? For a patient who's gotten themselves a ticket inside the hospital, we cover for those atypicals right off the bat. So I either use azithromycin or doxycycline. So it's ceftriaxone plus azithro or ceftriaxone plus doxy, okay? And this is where you take a step back and you're like, hey, if I think this patient has Legionnaire's disease, the data on doxycycline isn't great. So I'm going to do ceftriaxone and I'm going to do azithromycin, right? If you're like, maybe this patient has mycoplasma pneumonia, well, the data on azithromycin isn't as good. The data on doxycycline is better. So you take a step back and you're like, all right, I'll do ceftriaxone plus doxycycline. The beauty of it is, on your board exam, there's only going to be one right answer. There's only going to be one answer that has a beta lactam plus one of these. They will not give you ceftriaxone plus azithromycin as A, and on B, they won't give you ceftriaxone plus doxy. They will not make you decide between that. Okay? They will have one where it's like vancomycin and cefepime, and 3/4 of the people will pick that because this patient's in the ICU. And then option C will be the right answer, be ceftriaxone plus azithromycin. Does that make sense? So ceftriaxone covers a lot of my gram positives, right? Strep pneumo is the big gram positive. We need to cover gram positive diplococci. And then it covers a lot of my gram negatives, right? So Moraxella and Haemophilus are both gram negative coccobacillus, okay? So we're covering for those big bad community acquired bacterial causes. And then we're throwing on azithro or doxy to cover for Mycoplasma, Legionella, Chlamydophila. Again, it's a seesaw on which one is better, but starting one of those right off the bat is really warranted. Does that make sense? Now let's take a step back. So I just told you ceftriaxone, great beta lactam, third generation cephalosporin, covers a lot of gram positives, a lot of gram negatives. Which big bad gram positive does it not cover? MRSA. Does not cover MRSA, right? So it's not covering MRSA. And then which big bad gram negative does it not cover? Pseudomonas, right? So you're taking a step back and you're like, well, this patient has community acquired pneumonia. Yes, they have diabetes and COPD, but they don't have any MRSA risk factors or Pseudomonas risk factors, which we'll talk about in a second. I don't need to start them on big, bad, broad spectrum antibiotics. I'm treating them for community acquired pneumonia, okay? So ceftriaxone does a great job covering gram positive, gram negatives, does not have MRSA coverage, does not have Pseudomonas coverage, does not have anaerobic coverage, okay? The only cephalosporins that have like any anaerobic coverage are my second generation, like cefoxitin or cefotetan, which are like rarely used anymore. So please don't memorize those for your board exam. So now let's take a step back. What else, if this patient had to be admitted to the hospital or to the ICU, anything else you want to add on? So there's new data. It's called the Cape Cod trial. You can read about it. They've done a couple of them. They've shown in severe community acquired pneumonia, you can give stress dose steroids that sometimes can improve mortality or can improve time on the ventilator. So in a patient with severe community acquired pneumonia, give them hydrocortisone 50 milligrams Q6. Okay. That if you ever do an ICU rotation and you bring that up on rounds, your attending jaw will drop. They won't expect med students to know that. Now, because I don't have a question on this, because there's one more pneumonia question that's worth discussing. That's next. But let's talk about hospital-acquired and ventilator-acquired pneumonia, right? So what is the definition of hospital-acquired pneumonia? Not 5 days. Correct. 48 hours. Yep. So even less. We lower the threshold because that's how bad hospital-acquired pneumonia is. So if the patient has been in the hospital for over 48 hours and they develop pneumonia, hospital-acquired pneumonia opens up a new Pandora's box of oh shits, okay? Ventilator pneumonia, same idea. if they've been on the ventilator for over 48 hours and then develop pneumonia, now it's ventilator associated pneumonia. Okay. So maybe the patient comes in with like a pulmonary embolism. They're in the hospital. It's day 1 and they develop pneumonia. What would you call that? Community acquired pneumonia. It is still community acquired pneumonia. I'm still covering for my typicals and atypicals. I'm not even thinking about MRSA and Pseudomonas. Most doctors will. If you look at the guidelines, you look at the data, you shouldn't, right? You still treat them with ceftriaxone and azethro or cef and doxy. The other thing I'll say, let me just take a step back. We talked about ceftriaxone plus azethro or cef plus doxy is great for inpatient community-acquired pneumonia. You will also read in the guidelines, you can use levofloxacin by itself. Who's seen that? Yeah, no, yeah, okay. Yeah, does everyone saying yeah? No, okay. Levofloxacin can be used as monotherapy. You should not use it as monotherapy if the patient has bought themselves a ticket into the ICU, okay? But you will see that on board exam questions, patients admitted to the general floor, and you're like, this is community-acquired pneumonia. They're inpatient, and you're going to be looking A through F, and you're like, where the fuck is ceftriaxone plus azethro or doxy? And it's not on there, and they just have levofloxacin on there, and everyone gets that one wrong because they forget about levofloxacin or monotherapy with a fluoroquinolone. But now let me ask you this. Any drug obviously can have side effects. Fluoroquinolones are like the bane of my existence, right? Why do we hate on fluoroquinolones so much? QT, prolongation, tendon rupture. What else did I hear? Fuck up. Yep. So aortic dissections, aortic aneurysms, they can expand on those. Tendon rupture, QT prolongation. In older individuals, altered mental status is a big one. And then they can cause dysglycemia, both hypo and hyperglycemia. Really good drug, really good antibiotics, but man, they have a lot of side effects. Azithromycin, GI upset, okay, and then obviously QT prolongation. Please remember that. Any of my beta-lactams, GI upset, and then beta-lactams tend to be the most common cause of drug-induced liver injury, okay? Of the beta-lactams, Augmentin is the most common culprit in drug-induced liver injury. You will get a patient who's placed on Augmentin, and then they'll give you in the vignette like 5 days later, they've got right upper quadrant pain. AST, ALT are slightly elevated. The ALP, T-bili are elevated. That's drug-induced liver injury. That's what they're getting at. Augmentin is the most common cause. Okay, so if we have hospital or ventilator-acquired pneumonia, we now have to consider MRSA and Pseudomonas and other big bad gram-negatives. So when the patient has been in the hospital recently, or they've been on antibiotics recently, or they have other structural lung diseases, or they have a positive MRSA NARES. Does everyone know the MRSA NARES? Like a MRSA NAT in your test? Okay, we'll go over that in a second. So risk factors for MRSA and Pseudomonas, recent hospitalization, okay, recent antibiotics are going to be the biggest ones. For Pseudomonas, certain structural lung diseases like bronchiectasis, cystic fibrosis are a big one. Staph aureus, obviously previous history of Staph aureus infections, not necessarily MRSA, but just Staph aureus on its own. Living in kind of poor environments as well, where you are at risk to being around a lot of dirty things are other risk factors. But if you've been in the hospital for over 48 hours or on a ventilator for over 48 hours, you are exposed to a lot of these pathogens. And there's actually there's data pathophysiologically when you are very sick, some of your adhesins in your body, in your mucosal tract changes, and it allows gram-negative rods to hold on better. So like Pseudomonas usually should be in your GI and GU tract. Pseudomonas can start making its way up to places it shouldn't be. Also think about if you're on a ventilator, man, that ventilator, the trach tube you got has all of your secretions on there, just making all these biofilms and just colonizing all these things. And then you get a patient who's on the ventilator or they're hospitalized for whatever reason, they aspirate, right? That's just asking for aspiration pneumonia, okay? So 48 hours in the hospital, 48 hours on the ventilator. Now we're thinking about MRSA and other GNRs. So now you've got a patient who's they're hospital day 5. The hospitalist, you're the ID doctor. The hospitalist calls you, says, hey, they've got new cough, fever, pleuritic chest pain. Their O2 sats are 90% on room air now. We got a chest x-ray, shows a new right lower lobe opacity. What do you do? What do you start them on? We got to cover against MRSA, so what are we going to use? Vancomycin is great, right? Vanco, potentially linezolid, right? Linezolid is, we're not even going to talk about linezolid. That's got a lot of problems. It's good. It's going to some parts. Why not daptomycin? Daptomycin works against MRSA, but why not here? Not in the lungs. Why not in the lungs? Correct. Surfactant inhibits daptomycin. So if you got a lung infection, daptomycin ain't going to do shit, right? So vancomycin is a great first line for MRSA, okay? So I'm covering, vancomycin is a huge molecule, does really good at blocking the D-ALA portion of my outer cell wall or my outer cell membrane of my gram-positives. It cannot get through the thick outer wall of the gram-negatives, so it has no gram-negative coverage, but it's great for all my gram-positives. So Vanco will cover MRSA, and it will also do a pretty good job covering against strep pneumo, okay? So we're covering that way, right? Vanco isn't the best for strep pneumo, but it'll work. What do we cover? Then I got to think about Pseudomonas and other big bad gram-negative rods, right? My other big bad gram-negative rods are my Enterobacters. So things like Enterobacter itself, right? There's a million types. Kleb pneumo and Pseudomonas are going to be like the big ones that you want to understand. So what would I cover, right? If I got to cover against Pseudomonas, what can I use? Zosyn is a good one. So piperacillin, tazobactam. What else? Cefepime. There's one other big one that occasionally you might see used. Ceftazidime. Okay. So when I think about it, right, my cephalosporins, your cefepime is going to be great for Pseudomonas. It's got Pseudomonal coverage. Your ceftazidime, great for Pseudomonas. It's got Pseudomonas coverage. Okay. Neither of those cover for MRSA. So if I have a concern for MRSA and Pseudomonas, I can't just use one of those, right? Which cephalosporin covers MRSA? Yep. Number 5, 5th generation, ceftaroline, not cephalexin. Cephalexin covers MSSA. It is the first line option, one of the first line options for MSSA in your bloodstream. But MRSA, ceftaroline, is the only cephalosporin that we have that covers MRSA. Okay. So I take a step back and I say, okay, this patient has hospital-acquired pneumonia or ventilator-acquired pneumonia. What are my things that I cannot miss? I cannot miss MRSA, so I start them on Vanco, okay? I cannot miss Pseudomonas, so I start them on either Zosyn, which is piperacillin tazobactam, cefepime, or ceftazidime. Those are usually what you'll see in the guidelines, okay? Usually more cefepime and Zosyn, but every now and then you'll see ceftazidime work. Does that make sense? Okay? So, and then what you do, it's the same thing we would do for a patient that presents to the ED. You have a suspicion for hospital or ventilator-acquired pneumonia. We get blood cultures. We try to get a trach culture or a sputum culture. If the patient's awake and they're not intubated, we can try to have them cough up something from the bottom of their lung because we try to figure this out. But we have to cover for MRSA and Pseudomonas, because if we miss those are what kill patients, right? And then the beauty of it is maybe this is another gram-negative rod. Well, Zosyn, cefepime, ceftazidime are absolutely going to cover them. And maybe this is another gram-positive that we're not thinking about. Vancomycin usually will cover them. Most of the other gram-positives, right? So does that make sense to everyone? Okay. So let me just take it one step back because I really, yeah, what do you got? So usually in the hospital setting, no, right? Because like your atypical pneumonia, how does atypical pneumonia present? Exactly, right? Exactly. So it's a walking pneumonia, and it's usually right. Like, so my classic mycoplasma is my 18-year-old in college, military recruit, someone around a lot of people. It's a slowly progressive course. We're going to see the bilateral infiltrates. You can see erythema multiforme. You can see mucosal lesions. You can see maybe a macular papular rash, diarrhea. Same with like Legionella and Chlamydophila. Like these are like subacute long courses, okay? Your patient with hospital-acquired or ventilator-acquired pneumonia is going to be fine until you come around on them like in a couple hours and oh shit, they're sick as fuck. You really don't need to think about them. Maybe keep it in the back of your mind if they're not getting better with Vanc and cefepime. You're like, oh, did I miss something, right? Has this been building? But in the hospital, I absolutely need to cover MRSA and Pseudomonas and then my other gram-negative rods because that's what will kill the patient if I don't cover. But great question. So take a step back. Let's understand, right? Because pneumonia is still one of the like biggest killers of patients. it is still one of the most common things that gets a patient a ticket into the hospital. So I need every single one of you, regardless of what field of medicine you go into, you should understand how to approach pneumonia and what empirics I should start, right? You shouldn't be consulting ID for like a pneumonia case, right? If it's hospital acquired pneumonia, fine. But like community acquired, probably not. Okay. So again, the patient comes to you outpatient. You're in urgent care, right? You do your curb 65. If it's a 0, 1, maybe if they're really healthy and it's a 2, I can do outpatient. First question I have to ask myself, do they have any comorbidities, right? So big comorbidities, you think about heart, liver, lungs, kidneys, right? Those kind of things. Are they on immunosuppression, right? If they're checking any of those boxes, you're like, okay, they've got comorbidities and I want to treat them as an outpatient. If they have comorbidities and I'm treating them as an outpatient, I cannot use amoxicillin by itself or doxycycline by itself. When you have comorbidities like this, your body is just going to get colonized by a lot of bugs that it shouldn't. Things like Haemophilus and things like Moraxella, okay? So what I do is I start the patient on Augmentin plus an azithromycin or doxycycline, right? What does the Augmentin give me that amoxicillin doesn't, right? They're very similar, right? So amoxicillin, boom, and Augmentin is amoxicillin plus clavulanate. So what does that clavulanate do for me? Correct, right? It's a beta-lactamase inhibitor. And which type of pathogens have that beta-lactamase most of the time? What? Nope, other ones. Gram-negative. So if something's going to have a beta-lactamase inhibitor or a beta-lactamase, it's going to be gram-negatives most of the time. So that'll be things like Haemophilus, Moraxella, other gram-negatives like that. So when my patient has underlying comorbidities, I need to just assume they're colonized, they've got some big bad bugs in them that have this beta-lactamase. So right off the bat, if I want to treat them outpatient, I'm like, hey, you look relatively stable, you've got these comorbidities, I'm throwing them on amoxicillin plus clavulanate right off the bat so I don't run into treatment failure. Plus, I'm covering them for an atypical, azithro or doxycycline. Make sense? If they have, if they're no comorbidities, like our patient we did the case on, if they have no comorbidities, and you're like, okay, we're still going to treat you outpatient. They're relatively, their curb 65 was like 1. Now, if they have no comorbidities, amoxicillin or doxy by itself are appropriate. Okay? Does that make sense to everyone? All right. With the outpatient management, you might also see like using any other beta-lactam, which is fine. Like you might see a patient on like ceftonir plus doxycycline. But really, I want you to get like the Augmentin plus doxy or azithro, and then for a healthy patient, outpatient pneumonia, amox or doxy. Those are like your big frameworks. That makes sense? Then if they get admitted to the hospital and it's community-acquired pneumonia, we think about ceftriaxone plus azithro or ceftriaxone plus doxy. And if they're not in the ICU, we could consider levofloxacin monotherapy. All right. And then if it's hospital-acquired or ventilator-acquired pneumonia, we cover for MRSA and we cover for Pseudomonas and other gram-negative rods. So Vanco plus acefapine, azocin, or ceftazidime. Make sense? All right. Then let's quickly talk about lung abscesses. So lung abscesses, usually it's secondary to aspiration. Okay. So who's going to aspirate? Who are my patients, my classic aspirators? Those are the big ones, right? So alcoholics, patients with severe neurological dysfunction, post-stroke, Parkinson's, multiple sclerosis, ALS that has progressed, right? Patients who are like spastic quadriplegics, secondary to like cerebral palsy or things like that. Those are my classic patients, or patients who have like silent GERD, okay? Or what? Vomiting, exactly, right? And so sometimes the patient might not even know they aspirate. Sometimes it'll be very obvious, okay? Your job as a doctor is you need to differentiate aspiration pneumonia from aspiration pneumonitis, right? Aspiration pneumonitis is a now problem. Aspiration pneumonia builds over several hours, several days, okay? So aspiration pneumonitis occurs because you're swallowing vomit and you're swallowing some of these GI enzymes, right? Your pancreatic enzymes, some of your gastric enzymes, right? Your pepsin, things like that, and they damage the lung. Okay, so we get a febrile response, we get a leukocytosis, you'll see a new infiltrate, and you'll watch their fever will spike, and then it will quickly go back down, and that infiltrate after like a day or so will go away. Aspiration pneumonia, they'll have the history of aspiration, and it will be like 2 days from now they develop that infiltrate, cough, fever, pleuritic chest pain. Okay, aspirate. You think about the tempo of these diseases. Aspiration pneumonitis is like a now problem. Aspiration pneumonia usually takes at least 24 hours for you to really start seeing signs and symptoms. Does that make sense? All right. And I'll take a step back too. Fever does not mean infection, right? I hope you guys have learned that. I can't tell you how many times on just the last month when I was on ID, we got consulted for a patient with new fever and leukocytosis. I'm like, did you consider other causes of fever and leukocytosis, right? Fever is a response to some sort of inflammation, as is leukocytosis, right? And if you want to learn the mechanism of fever, I can teach you that. I don't think I need to bore you guys with any of that now. But fever and leukocytosis does not mean infection. It could mean infection, right? So the patient aspirates. It classically goes to the right side of the lung due to the angle of the bronchi being more vertical, right? So we'll classically see like right lower lobe, potentially right middle lobe, posterior opacity. If they develop an abscess, what do? What antibiotics now? Cover your anaerobes. I like it. Someone said this antibiotic before, and I can't remember. So first line is usually ampicillin sulbactam. I think was that you? Yeah. So ampicillin sulbactam is a great option. Unison, because Unison is great anaerobic coverage. Ampicillin and sulbactam will also then both cover gram positives and gram negatives together. Okay. Because when I aspirate, we get all of my oral flora, some of my GI flora. So we're going to get a polymicrobial infection, positives, negatives, anaerobes all in there. So we got to cover for all of them. So ampicillin sulbactam tends to be a great option. You might also see ceftriaxone plus metronidazole, or okay, so Flagyl. Because again, ceftriaxone will cover a lot of the gram positives, a lot of the gram negatives, and then Flagyl covers anaerobes. Okay. My beef with that is like metronidazole. All the data is really on below the diaphragm infections. So why the frick are we using it for a lung abscess where that material is clearly coming from above the abscess? But it's still used. Ampicillin sulbactam is the go-to. So we do ampicillin sulbactam or ceftriaxone metro. Should I drain this abscess? So the key is you have to understand exceptions to the rule. Most abscesses we'd love to drain. Lung abscesses are the exception. Okay, a lot of really valuable tissue in the lungs. Oftentimes, draining the abscess causes more problems than not. So usually these lung abscesses go away on their own with proper antibiotics. Okay, so most of the time, lung abscesses, ampicillin sulbactam or potentially ceftriaxone metro. Usually we don't drain it right away. Okay, that makes sense? All right. And then let's talk really quickly about complicated pneumonic effusions and empyemas, because that's the last little bit of this process. I do want to, because I forgot to mention it, we talked about the MRSA-NAIRS really quick. MRSA-NAIRS is a NAT test. You basically, you'll tell the nurse, I just want a MRSA-NAIRS. They swab the inside. Do you have a question? Okay. They swab the inside of the nose, and we run a quick PCR. We run a NAT test on them. It has really tremendous negative predictive value, right? Some studies even like 99%, but like most of them, 92 to 97%, okay? So what does that mean? If they have a great negative predictive value, if that MRSA-NAIRS test comes back negative, I can be very confident they do not have MRSA, okay? That's what that means. The positive predictive value is around like 50%. So if it's positive, maybe this is an infection cause from MRSA, maybe it's not. All this tells me is if they're colonized with MRSA. MRSA loves the skin, and it absolutely loves the nasopharynx, okay? So if I'm like, do I need to cover MRSA empirically? Get a MRSA-NAIRS. You'll get that data back in like an hour or so. If it comes back negative, I don't need vancomycin, right? That's the way you should think about it. If it comes back positive, you got to take a step back and do a little bit more thinking. Do I think they have a risk for this being a MRSA infection? Does that make sense? Okay. What was your question before I move on? The empyemas and stuff? Okay. So what is a pneumonic effusion? It's a spectrum, right? We have uncomplicated pneumonic effusion, complicated pneumonic effusion, and empyema. Okay, so a pneumonic effusion is just you have a pneumonia and you have a pleural effusion, right? A complicated pneumonic effusion is now you got some inflammation going on in that in that effusion, and then an empyema is, oh shit, the pleural fluid has now gotten infected. Okay, so empyema is like the oh shit. Complicated pneumonic effusion is also pretty bad, right? But an uncomplicated is, hey, they have a pneumonia and they just on top of it have a pleural effusion. Okay, so how do I tell, right? If they have a pleural effusion, what do I do? Right? I can do a thoracentesis, and what do I need to order? Yeah, or like what tests am I? LDH, Light's criteria is what I'm getting at, right? So what are Light's criteria? Yep, absolutely. So your Light's criteria, right? Everyone always gets this wrong. Light's criteria, you only need one, okay? You only need one to call it an exudative effusion, okay? So what I do, we'll pull it, we'll get a lot of data off of that pleural sample, but really, I'm going to look at the LDH and the protein, okay? Those are the big things I care about. We can look at the cell count and the differential and the cytology as well. But the LDH and the protein are what's going to help me to make this exudative versus transudative. So what I do is I take the pleural protein divided by the serum protein. If that is greater than 0.5, that ratio, that's a check, right? We just need one. So if they meet that, I don't even need to do any of the other tests, right? I don't need to look at any of it. They've got exudative. I can then look at the pleural LDH divided by the serum LDH. If that ratio is greater than 0.6, oops, there's another check, right? And then I can look at the pleural LDH. If that value is greater than 2/3 the upper limit of normal for the serum LDH, then we also meet that, right? So let's say at Frater, I don't know what the upper limit of normal is, but let's say the serum LDH upper limit of normal at our Frater hospital is like 300, okay? So if their pleural LDH was like 250, well, that's 250 divided by 300 is greater than 2/3. So that's like what I mean by that. There's also new data now. You can get a pleural cholesterol. If that's above 55, that's even a better test than these Light's criteria to determine exudative, right? We can take it back to M1, M2 year. Exudative, I think about capillary permeability. So I think about infections. I think about cancers, things that are going to make my vessels leaky. Transudative, we think about increased hydrostatic and decreased oncotic pressures, right? Heart failure, cirrhosis, nephrotic syndrome, things along those lines, okay? So in uncomplicated pneumonic effusion, they have the pneumonia. They've met Light's criteria. Maybe they haven't. Maybe they have an effusion for another reason. But then we take a look at the fluid from the pleural sample, and it doesn't look purulent, okay? It doesn't look grossly purulent like that. And then we do a gram stain on it, and nothing grows. Uncomplicated. We take a look at the pH and the glucose. In an uncomplicated pneumonic effusion, the pH is above 7.2, and the glucose is above 60. Make sense? Complicated pneumonic effusion, I do the same things. We meet exudative, all right? In this case, if it's a complicated pneumonic effusion, maybe the fluid's starting to look a little purulent, and the pH is going to be less than 7.2, and the glucose is going to be less than 60, okay? But there's not going to be anything grown on gram stain, okay? Nothing grows from the fluid. We just now, we've got something brewing, but we haven't actually had a full-born infection. Make sense? The pH is low because we're undergoing anaerobic metabolism, okay? The glucose is low is because, again, we're undergoing anaerobic metabolism, and we're using up a lot of that glucose to go through glycolysis. Make sense? Okay? And empyema then is pH less than 7.2, glucose less than 60. We've got frank purulence coming out of the pleural fluid, and the gram stain starts growing something, okay? The reason it's really just semantics, because for both complicated pneumonic effusion and empyema, what's the treatment? We do our ampicillin sulbactam or Cef Metro. Yep. Absolutely. Yep. So for either complicated pneumonic effusion or empyema, again, it's like semantics for like, scholarly discussion. And if you want to be as precise as possible, we're going to call pulmonology or crick care or whatever, they're going to stick a chest tube in and they're going to do TPA and Dornase probably multiple times. Okay. That's going to help relieve that effusion and make sure all that nasty infected fluid gets out of there. Does that make sense? We're good? All right. Since we just spent a lot of time on pneumonia, I'll just go to 119 and just give you this guy. He ends up failing his treatment for pneumonia. So in this case, right, if you fail, like let's say they got admitted to the hospital, they're on ceftriaxone and azethro. Okay, let's say I'll even make it simpler for you. We've ruled out like the atypicals, right? We got a respiratory panel. We did the serum urine antigen. We're like, I don't think it's an atypical. So he's already on ceftriaxone and azethro. It's day 3 of his hospitalization. Still got a high fever. He's still got a cough, pleuritic chest pain. He's still hypoxemic. What do we do? What do we think about? We kind of talked about it. Like, is this pneumonia? Is this, are we treating the right bugs? And let's say yes and yes. We've done that thought process. Yes and yes. So what could be causes of him not having his treatment going the right way? Maybe. Well, we're going to say it's the same pneumonia though. Okay. Correct. Right. So when they've got community acquired pneumonia, we're treating appropriately, right? We're covering our bases. This is where you got to start thinking, okay, is there something else in their lungs that's blocking the antibiotics from getting there? Or do I not have source control, right? Am I not controlling this infection? So great first steps would be get a chest CT. Do they have a parapneumonic effusion that we just talked about? Do they have a lung abscess? And then if you don't see anything on that, that's when you start thinking about a bronchoscopy, right? Do I actually need to go invasively and look around their lungs and remove something, right? Or get a sample. This would be another instance where you could think about some of those more rare causes like histoblasto coccidio. Okay. Yes. Correct. Yep. Any disease where you have like pretty much defined your syndrome and they are not getting better in the expected time course, you want to think about abscesses or something abnormal in your anatomy that's blocking source, that's stopping source control. And what I mean by source control is like if the patient has an empyema, like so they came in, in the ED, they got a beautiful chest X-ray, a beautiful chest CT. All you saw was the left lower lobe opacity. They had no effusion. Great, you start them on ceftriaxone and azethro. Now it's hospital day 3. That doesn't mean in those 3 days they haven't developed an effusion and you just haven't caught it, right? So that's when we think about it. It's the same thing with pyelo. The classic example is you have a patient with pyelo. They go like 48 hours, 72 hours. They're still spiking a fever, still some flank pain, right? That's when you consider, do they have a perinephric abscess or something else going on? Get a CT A and P and check for that, right? Because then we have to call IR and they got to stick a needle in there and remove that. Because if they have an abscess or we don't have source control, that infection is just going to keep brewing, right? We're not going to take care of it. Does that make sense to everyone? All right. Yep. Oh, okay. All right. That's lung, like lower respiratory. I don't know if we're going to have time, but I have upper respiratory. I can just talk about it really quick because upper respiratory isn't as bad. What would you do for, when would I treat rhinosinusitis? What's like your classic, like step 2? No, rhinosinusitis. So like sinusitis, right? So infection of the sinuses. 10 days, I like it. Yep. Yeah. So there's 3 main indications to treat rhinosinusitis with antibiotics. It's if they initially present and they're like super freaking sick, like I'm talking high fever, they like, oh shit, like this guy needs to go to the hospital, treat them, right? The second one would be they've made it like 7 to 10 days and they're still not getting better. Then you start to think, okay, is this bacterial? And then the third one would be they had initial rhinosinusitis, they got better, and then they got sick again, right? Second sickening, right? That's when you think about viral now predisposing to bacterial, okay? So the treatment for outpatient rhinosinusitis is, yep, it's the same as my otitis media, right? Because it's all connected, right? My pharynx and then my sinuses and my inner ears or middle ears, they're all connected. They're same in the anatomic space. We need to consider the anaerobes that live in my mouth, okay? That's what we're gonna cover for with augmentin, right? Amoxicillin and clavulanate. Going to be really good for gram-positive, gram-negatives, and anaerobes. Make sense? Okay, that's rhinosinusitis. How about pharyngitis? What are the most common causes of pharyngitis? No. Most common causes of pharyngitis. Viral, right? Viral pharyngitis is the most common cause of pharyngitis. You got your echovirus, enterovirus, adenovirus, RSV can even cause it. Things like that, right? The one you got to worry about though is strep, because if I miss a strep pharyngitis, I could put my patient into a world of hurt, right? We could get what can occur if I don't treat strep pharyngitis? Rheumatic fever, right? What if PSGN? What's the relationship there? Correct, right? Sorry, not correct. Other way around. I said that. Yep. So PSGN, I can't stop it, right? That doesn't mean every patient with strep pharyngitis or strep impetigo will get PSGN. It just means even if I treat it, they still have a risk for it, right? It's a type 3 hypersensitivity. We get immune complex C formation. But the data shows if they have strep pharyngitis and we treat it appropriately, we can reduce the risk for rheumatic fever, right? And most kids who get PSGN recover perfectly fine. Most kids who get rheumatic fever do not recover perfectly fine, right? And they're going to be having problems for the rest of their life. So is there a scoring system that comes to mind when you think about strep pharyngitis? I'm looking at you, scoring system queen over there. Do you know this one? Yeah, Centaur score. What did you say? Malin Patty is great for if you're going to do anesthesia to see how big, like how closed off their throat is. So that's like you'll get questions on that too. Is if you want to do some sort of procedure, you got to do the Malin Patty score to see how hard of an intubation it's going to be. So the Centaur score is what you should be thinking in your head as you're talking to a patient with pharyngitis, right? So the C stands for the cough being absent. The E is exudates on the back of the throat. The N are nodules, right? So like usually it's like posterior, anterior cervical adenopathy. And then the N is a high temperature, right? They've got a temperature above 100.4. And then we can add points if they're in the right age range, right? So strep pharyngitis is classically between ages of 3 and 14. So that adds a point. If they're 14 to, I think it's usually 45 or 44, we give them 0 points. And if they're kind of on both ends of the spectrum, we actually take a point away because that's how rare strep pharyngitis is in those patients. The higher the score, the more likely it is that they have strep pharyngitis. And usually, if you look like a score of anywhere between 2 and 3, I'm going to try to get my rapid strep test. And that's a good, like, quick one, okay? But if that rapid strep test comes back negative and you're like, I still think this patient has strep pharyngitis, that's when you order a bacterial culture, okay? You order the bacterial culture and then you can usually treat empirically. Treatment for strep pharyngitis, again, is going to be usually amoxicillin. Every now and then you'll see amoxiclavulanate used. I don't need to, if it's strep pharyngitis, do I need the anaerobic coverage or that clavulanate? No, right? So it's having good antimicrobial stewardship. I don't need to give them clavulanate. I can just give them amox. Does that make sense? Okay. Otitis media, we just talked about. Strep pneumo, Haemophilus, Moraxella, common causes, augmentin. What if the outside of their ear, super painful, they've got mastoiditis, they're old, they've got COPD, diabetes. What is this? Pseudomonas, right? And so what's a clinical syndrome? Hmm? Yep. Malignant otitis externa, right? So that's an infection of the external auditory canal. And when it becomes malignant, we start degrading the bones around it, right? So you can get osteomyelitis in your mastoid bone and some of these other bones. That is as bad of an infection as you can get. Like it's one of the worst ones. That's hospital and that's high dose IV anti-pseudomonal drugs that we talked about. Like Zosyn would be one of the best ones. Okay, and the last upper respiratory I want to talk about. What if you have a 19-year-old female? She comes to your ED, but you read on the chart or you hear from mom, she went to an urgent care for like a sore throat. They gave her some antibiotics. They gave her like some amoxicillin. She got a little bit better, but then she got really, really bad. Now she comes in, she couldn't protect her airway. So you had to intubate her. And then you see on your exam, her internal jugular vein is like a palpable cord, we'll call it. What is this? You do blood cultures and you see gram-negative rods. Gonorrhea, that would be fair game, but this is something different. When I think about it, it's the internal jugular vein gives it away. Septic thrombophlebitis in the internal jugular vein. Does that mean anything to anyone? Lemierre's disease. Who's heard of that one? Okay, Lemierre's disease is a pretty high yield one because if you miss it, the patient will die. It is caused by Fusobacterium necrophorum. I've seen several questions where they literally just give you the vignette I gave you. It's classically younger individuals, okay, who are predisposed to this. They have some sort of first sickening. It predisposes Fusobacterium, lives in my upper respiratory tract. The Fusobacterium then seeds on to that damaged tissue. It causes septic thrombophlebitis in the internal jugular vein and causes a severe pharyngitic picture, super high temperatures. The patients are on like death's door. And then that septic thrombophlebitis can potentially get all over the place, right? It can embolize elsewhere. So they could have pulmonary findings. If it gets systemic, they could even get like cerebral findings, okay? Please, if you haven't heard of, I've got a section on Lemierre's disease in here, so read about it. But if you haven't, go read a research article on it because you need to know Lemierre's disease, okay? Treatment for that, right? It's a gram-negative rod. We usually use like something like Zosyn, right? It is going to be really good. Does that make sense? Upper respiratory, lower respiratory, it's all in here. Okay, let's go to 121. This is a good one to discuss. 68-year-old man presents to the emergency department with 3 weeks of intermittent fevers, night sweats, progressive dyspnea. He underwent mechanical aortic valve replacement 8 months ago for severe aortic stenosis. His post-op course was complicated by a sternal wound infection that required debridement and prolonged antibiotic therapy. He has been compliant with warfarin. We see he's got an elevated temp. His blood pressure is okay. Pulse is elevated. Respirations are elevated. We see a new harsh systolic murmur and soft early diastolic murmur at the left sternal border. We see bilateral crackles are heard at the lung bases. No peripheral stigmata of endocarditis are noted. The sternal wound appears well healed. There's his labs. We get 3 sets of blood cultures. The TTE shows a normal functioning mechanical aortic prosthesis with acoustic shadowing, limiting visualization of the perivalvular region. No vegetations are clearly identified. I want you to tell me what you want to do next for this patient. So take like a minute or so and think about that.
What else are we gonna do for this guy? Well, let's get a chest X-ray to see if he has chronic. So because of that. So what's the news? Maybe it's supposed to do all of them.
Missed the obvious answer, Andrew Rob. There have been so many times in your report. Don't take it into the right shot. And 9 times out of 10, it's right.
He doesn't have an MI. That's what he.
All right, just to make sure we can touch on some other stuff. What do we need to do here for this patient? Why? Yep. So we need to do a TEE. Okay. So whenever you have a suspicion for endocarditis, if the TTE is very fast. It's very good for just a quick view, but a lot of the times the visualization is limited. So if we have a suspicion for endocarditis, we got to get visualization of that vegetation. So we do a TEE that gives us a better view of the backside of the heart, and it gives a better view of the perivalvular region where you can often get abscesses. What do we want to use antibiotic wise? If we've gotten blood cultures, okay, so hopefully those will grow something. We're going to get the TEE. Okay. What do we want to do antibiotics wise? Ceftriaxone? What do you think about his hospitalization history? This guy's probably got a high, we should have a high suspicion of MRSA and other big bad gram-negative rods, right? He's got the antibiotic history. He's got the hospitalization history. Let's start him on vancomycin and cefepime would be reasonable, okay? Again, this would be a great guy. If you get a MRSA NARS that comes back negative, I can pull off the vancomycin, okay? So not necessarily, because this guy has a prosthetic valve and the prosthetic valve messes everything up, right? Prosthetic valve allows biofilm formation. So maybe staph epidermidis, right? Which is like your classic. But tell me about, what do you know about staph epidermidis? Staph epidermidis is classically methicillin resistant. So I would still need vancomycin there, right? So that's kind of the way you think about it. But yeah, because they have a prosthetic valve, the prosthetic valve kind of can blunt your fever response. It can blunt your leukocytosis, and it can allow this subacute process to form. And then I heard over here, right, chest x-ray. This guy probably has crackles because he's got a big old vegetation somewhere in his heart, and he's got an acute heart failure. And then I also heard, why does this guy have anemia? Why do you guys think this guy has anemia? Maybe lysing the red blood cells. What would be a better physiological reasoning? He's got a massive inflammatory response going on, so this is probably anemia of inflammation, right? Maybe lysing the, if you're thinking about like Heidi syndrome, maybe. I'll give you guys that one. Okay, we're good on that. Okay, I'll talk about we'll talk about meningitis really quick to make sure you guys get the framework, because I want to cover a few more questions. Okay, yep. Meningitis. What are my classic meningitis bugs that I like, community acquired meningitis that I need to cover? H influenza, subpneumo, Neisseria meningitis. Perfect. Those are like the big bad ones, right? Strep pneumo is the most common cause of community acquired meningitis, right? Hib is really going downhill since we have a great vaccine for it, right? And then Neisseria meningitis, we really need to consider in, like college age, high school age, military age individuals, but really like anyone could get it. But those are the patients in close contact that can get it. There's obviously things like aseptic meningitis caused by viruses. There are fungal meningitis. There's other like weird ones, like you could consider like nocardia causing brain abscesses, right? We can talk about that in a second. You really need to define who your host is, and then you define the meningitis, right? So if my host is a relatively healthy patient coming off the street, I probably don't need to worry about like cryptococcal meningitis, tuberculosis meningitis. I can be pretty safe, thinking about my big ones, right? If my patient is a 55-year-old, what else do I need to consider? Listeria, right? If they're an infant, I also need to consider listeria, right? So that's like the big framework. And like, how is meningitis going to present? It's going to present usually with a high fever, photophobia, phonophobia, neck stiffness, right? We can do the Brudzinski sign, where you pull on the back of their head, and that's going to cause pain down their spine and their neck. You can do the Koenig sign, where you have them extend their knee. So I pull it behind, I grab behind their knee and have them extend their leg, and that's going to cause stress on their meninges as well, right? So first things first with meningitis, I'm like, oh shit, this patient walked into the ED. I think they have meningitis. What do we do? Be very careful how you answer this question. Okay, why? When? I'll say when. Always? So if you look, like when they first started to find out that just doing a lumbar puncture on anyone could lead to herniation, they were like, oh shit, should we look at their brain and consider the patient? So way back when they started figuring this out, they came up with the mnemonic FAILS. So focal neurological deficits, altered mental status, immunosuppression, some sort of lesion that we know in the brain or that we find on the brain, and a history of seizures, okay? They did a bunch of research and a bunch of literature, and they found that altered mental status was not like a good test on if we should do CT scan. So they threw that out, okay? Because like most patients with meningitis are just going to be really lethargic and pissed off, and they're going to seem altered, but it's really not anything more going on. So when I think about it, if the patient has a focal neurological deficit, or if they tell you on a vignette they have papilledema, intracranial pressure, right? Boom, done. If they are immunosuppressed, they have a history of HIV, they've been on long-standing chemotherapeutics, long-standing steroids, I might want to get a CT scan. If we know they have a history of brain cancer, or they had a history of brain cancer, I might want to get a CT scan. If they had a recent seizure or they have a history of seizures, I might want to get a CT scan. Okay. So all those, right? And STEP is going to be very obvious about it, right? They're going to tell you they have a focal neurological deficit or they have papilledema. That's their favorite. They have papilledema. So what do? I get a non-contrast CT scan of the head really quick, and I can see, do they have anything going on up there, right? Because the concern is if they have increased intracranial pressure and I stick a needle into their lumbar spine, we're removing some of that pressure and their brain might herniate, right? So that's the concern. So first things first, we rule out any of that stuff. And then we'd like to get, I heard over here, blood cultures and lumbar puncture cultures, right? CSF cultures, right? So we do that. We send that off to the lab. Hopefully that comes back soon. What do we start the patient on? Again, you need to ask yourself, who is my patient? Right? So let's say it's a 40-year-old male, no past medical history of anything coming off the street. What do we do? Ceph what? I like ceftriaxone and vancomycin. What else? Anything else you want to add? That's what I was asking. Do you do anything else? Why do we do dexamethasone? Correct, right? So they have done studies. Dexamethasone has slightly improved mortality, and it has improved neurological and otological recovery in patients with strep pneumo adult meningitis, okay? Hasn't really had the same effect on Hib or Neisseria meningitidis. It's really just strep pneumo. So most of the time, right, if we have someone who's not immunosuppressed, they're not over the age of 50, and we've got an adult outpatient or adult community-acquired meningitis, we got the lumbar puncture, we got the blood cultures, vancomycin plus ceftriaxone plus dexamethasone would be a great starting. If the cultures come back and it's not strep pneumo, we can probably pull off the dexamethasone because it hasn't shown effect. But they will often ask that as like empiric, okay? If the patient is 70 years old, you got to add ampicillin, okay? If the cultures come back and it's not a gram positive, it's a gram negative, I can pull off the ampicillin, right? Because Listeria is a gram positive rod. Does that make sense? Okay. Then if it's a 70-year-old man, he's got significantly altered mental status. He had a seizure. We got imaging. Let's say they ended up doing a brain MRI and he's got a temporal lobe lesion bilaterally. What is this? HSV. So what do we got to add on that? Acyclovir. Okay. HSV will often cause a bloody tap, right? Because we're causing all this necrosis up in the temporal lobe. We're going to get a lot of blood in that CSF, right? So that's another thing you might see. Does that make sense for meningitis? Okay. Then there's something, of course, called hospital-acquired meningitis, right? Where the patient's been in the hospital for many days. This is classically after some sort of neurosurgical procedure where they're putting maybe a shunt into the CNS, right? In some aspect. We have now opened up a communication between our skin and our CNS, right? What lives on my skin? My beautiful streps and staphs, right? And now this patient has been in the hospital for a long time, so we can get gram negatives where we don't want them either, right? So now if the patient has hospital-acquired meningitis, we got to do like vancomycin plus, a cefepime, azocin, right? Things like that. Does that make sense? Okay. The last thing I'll say, what do you know about cryptococcal meningitis? Most of the time, immunocompromised. I will tell you, Cryptococcus gattii can cause meningitis in non-immunocompromised. Cryptococcus neoformans is your hallmark, right? That can cause pulmonary and meningeal problems in immunosuppressed patients, right? So cryptococcal meningitis is going to be more of a subacute course. They're going to tell you in the vignette, or you're going to see in real life, the patient's got a history of HIV, maybe poorly controlled, maybe they've got immunosuppression. patients with cryptococcal meningitis classically have increased intracranial pressure. So you might see focal neurological deficits, papilledema. We'll do a CSF culture. And what should we do if we have a concern for cryptococcal? What should we tell the lab? India Inc., right? So I would tell them India Inc., and we would send a CSF cryptococcal antigen, right? Which should come back pretty quick, okay? So if I have concern for cryptococcal meningitis, what do I start? I like amphotericin. And what else? Are you just going to start them on ampho? Yep. Amphotericin B plus flucytosine for usually 2 weeks, okay? What do I do after those 2 weeks? Yep. So then I pull those off and I do high-dose fluconazole, usually for 2 weeks. And then I do low-dose fluconazole for many, many weeks to months, right? Then there's the weird question of, yes. No. Flucytosine is the precursor to 5-FU, fluorouracil, which is like a chemotherapeutic, but it also works really good on fungi. Fluconazole is an azole, which messes up your fungal cell wall. Okay. Correct. Yep. Not that I know of. Yep. So then the question is that you might get asked on a board exam or in real life is if this patient has cryptococcal meningitis and you diagnose them with HIV, so it's new HIV to them, right? They have this cryptococcal meningitis, and you're like, I want to start them on antiretroviral therapy. The question is when, right? Have you guys come across this in your studies? No. Okay. Yeah, when to start them on ART if they have cryptococcal meningitis. So this is like a hot topic right now. For any patient without cryptococcal or TB meningitis, at least for step 2, step 3 land, we try to start the ART just now. Okay, it's when you have cryptococcal or TB meningitis that are such extreme inflammatory responses. If I give them ART right away, we've seen in the literature it brings their immune system back up, and it really will go after the infection, and it will cause a lot more problems than good, right? Because this patient has basically not had a cellular dependent immune system for X amount of time, and we've just all of a sudden given them back. They've got a really bad brain infection. That immune system goes up there, and it just causes all bunch of havoc. So they've done a lot of studies, and you'll see different things in the literature. They're coming more to a consensus that usually you treat them for cryptococcal or TB meningitis for anywhere between like 10 to 20 days, and then usually you can start the ART. You'll see different stuff in the literature. The way they'll ask it on a board exam is like, when do you want to start ART? And it will be like now in like 2 days after treatment when they leave the hospital, or it'll be like several weeks. You'll just pick the several weeks, okay? I'm not sure how exactly I've only seen one question on it. So, but that's like it's called IRIS, Immune Reconstitution Inflammatory Syndrome. If you want to read up about it. But if they get that, you just give them steroids, right? And pray to God that they get better. All right, so that's meningitis. We talked about HSV encephalitis. Most encephalitis are caused by viruses. So we really only have good treatments for HSV, CMV, right? Are my 2 big viruses that we really have treatments for. Obviously, like the flu and stuff like that, we have some stuff, but those aren't going to cause meningitis. Let's talk about brain abscesses really quick. What is a predisposition to a brain abscess? We've talked about some of them. Yep. Everything's connected, right? For my upper respiratory tract, it has a direct connection back to my meninges and my CSF. So tooth abscesses, sinusitis, otitis media are all risk factors, right? So the classic cause of a brain abscess that's caused by bacteria, one of the biggest causes is strep viridans, okay? Your viridian species. So if they ever ask you, what do you think is growing here? Strep viridans is a very fair answer. For brain abscesses, right, we have to use usually some sort of anaerobic coverage. So like ampicillin sulbactam tends to be a pretty good option. If we need to cover for MRSA or others, right, we can add that on. And then brain abscess is going to be one of the ones where we absolutely have to try to drain that or remove it, right? Okay, so unlike the lung abscess. What do we know about nocardia brain abscess? Because that's one I've seen before as well. So what is nocardia? gram-positive, filamentous branching rod that is partly acid-fast staining, right? Who is going to get nocardia? Who is my host? Immunocompromised, right? So nocardia, classically lung and brain abscesses, right? What is the treatment for nocardia? Correct, right? So TMP SMX is the backbone. If they've got shit going on in their brain, you probably got to give them a carbapenem too, okay? Because it's that bad. But for your board exams, TMP SMX for nocardia, which is a gram-positive filamentous rod, branching filamentous rod that's partly acid-fast. They will try to fuck you up because there's also, what's the other one that's very similar to nocardia in terms of its shape? Actinomyces, which is a gram-positive filamentous branching rod that is not acid-fast, okay? So you're like, oh shit, right? Maybe you don't remember that acid-fast. I don't care, right? If I take a step back and I'm like, well, what do these bugs do, right? Nocardia likes the lungs and the brain. Where's actinomyces going to cause problems? The jaw, so cervical facial, they classically have these massive, lumpy, like abscesses that have a draining sinus tract that pull. What's the classic buzzword? What do they drain? Yeah, like sulfur granules. Actinomyces is an enteric pathogen, so it causes a lot of GI problems. And then in women, it loves your IUDs. It loves the copper IUD specifically. I've seen several questions on that where the OBGYN is going in and they do a culture of the IUD and they find actinomyces. That right there is an indication, oh, we got to remove the IUD. Okay. So actinomyces, how do we treat that? What? I heard penicillin. Penicillin. Penicillin is going to be my go-to. Doxy, I'm not sure if that's going to have great coverage, but penicillin is first line. So they're going to get you by having, it's going to be one of those, and your nocardia is TMP SMX, your actinomyces is penicillin, right? All right, let me just we'll do a few more, and then we'll call it a day. All right, let's go to slide 131. That's a good one to discuss. So yeah, obviously the ones we don't discuss, do on your own. I'll just go over now. If you ever get a patient who has a liver abscess that grows Yersinia enterolytica, do you know what we need to test this patient for? Yersinia enterolytica loves iron. There's your hint. Hemochromatosis. If you ever see Yersinia enterolytica in a liver abscess, like that's the main pathogen in the liver abscess, that is like almost always, at least for a board question, hemochromatosis. Okay. Usually I think like the value is like 60% of Yersinia in liver abscesses. Those patients, like 60% of them end up having hemochromatosis. So hemochromatosis, you think about your polyarthralgias, classically in the MCPs. You think about potentially your low libido, erectile dysfunction from pituitary. You think about diabetes, bronzing of the skin, big liver, right? Elevated AST, ALT. Okay. Yersinia enterolytica in a liver abscess. All right. So let's do 131. 56-year-old man with decompensated alcoholic cirrhosis presents to the ED with 2 days of diffuse abdominal pain, fever, and confusion. He was hospitalized 3 weeks ago for hepatic encephalopathy and was discharged on lactulose and rifaximin. He has not been taking prophylactic antibiotics for SBP. On exam, he's got an elevated temp, elevated heart rate, relatively low blood pressure, respiratory rate 22. He's disoriented to time and place. Abdominal exam reveals diffuse tenderness with mild guarding but no rebound. There's moderate ascites and lower extremity edema. Lab studies show a white blood cell count of 14,200. With elevated neutrophils, he's got an elevated creatinine, low albumin, elevated bilirubin, elevated INR. We do a diagnostic paracentesis that shows the following. So I want you to tell me what should we do for this patient antibiotic wise, if we need to do anything.
like,
Oh, yeah.
maybe you would change it.
Yes.
I think the liver.
Yeah, for sure. But
I can't.
We did it. Yeah, we got the. We had five.
yeah,
So you know.
So with the grams.
it's like.
Yeah. In Arizona.
Yeah.
It's not real high.
All right, what do we think? Yeah, what should we do? First off, should we treat them or is this something else? Yes. Okay. Why? Why should we treat them? Why is this SBP? Okay, so in the acidic fluid, neutrophils over or PMNs over 250 is an indication. What if the gram stain comes back negative? Do we still treat them? Really? Yeah. So as long as the PMNs are above 250, we treat. I don't care if the gram stain comes back. So your key distinction then is how do we treat them, right? And the key is who is your patient? And this guy has a history of recent hospitalization that we need to take into account. So your classic board exam is probably not going to give you that hospitalization. They're just going to ask you, how do we treat community-acquired SBP, spontaneous bacterial peritonitis, okay? Infection of the peritoneal fluid, usually in a patient with really bad ascites from cirrhosis or nephrotic syndrome or X, Y, or Z. So if this were just community-acquired SBP, what's the standard of care? Empiric antibiotic. I'm sure some of you have used it in this exact scenario. Not Zosyn. Ceftriaxone, a third-generation cephalosporin, is usually first line for community-acquired SBP. Okay, that is like as high yield as any fact I've shared today. SBP, community-acquired, PMNs over 250. I don't give a fuck about the gram stain. Okay, if the gram stain comes back and we get data on it, great, right? Empiric treatment, ceftriaxone or another third-generation cephalosporin. Okay, if this is hospital-acquired or they have a recent hospitalization, now I got to think about, okay, do they have multi-drug resistant SBP, right? So this is another key point, okay? In a step 2 vignette, they are just going to literally hold your hand and they're going to tell you this patient has an extended spectrum beta-lactamase infection, okay? Extended spectrum beta-lactamase means they have a beta-lactamase that is not going to be able to get inhibited by sulbactam, tazobactam, or clavulanate, the beta-lactamase inhibitors we have, right? So you're like, oh shit, how do I treat that? How do I treat, what is the first line option for an ESBL organism? This is, you absolutely have to know this for step 2 and beyond. Not S3NM. So S3NM is a monobactam, which is great for gram-negative aerobes, okay? Metronidazole? No. Your patient's dead. Your patient's dead. Yes. Carbapenems are gold standard. They are first line for an ESBL. At your stage, that's all you need to know. If you want to become an ID doctor, there's a lot more you got to know. But if you are on the wards or you're the hospitalist in charge and your patient's culture comes back with an ESBL organism, right? And the lab's not going to say with big red colors, like this is an ESBL. You're going to look at the susceptibilities and every single beta-lactam is going to be resistant. And you're like, oh shit, this is an ESBL. You start the patient on an empiric carbapenem, okay, and you call ID as fast as you fucking can, okay? So with regards to the carbapenems, I will just, this is like a really good fact as well. Ertapenem does not cover which big bad bug that we've talked about. They will get you on this on board exams. Nope. Ertapenem does not cover Pseudomonas, okay? So they will get you on that one, okay? And then imipenem, right? So the 3 big carbapenems, meropenem, ertapenem, and imipenem, right? Those aren't like brand new to you guys. You guys have heard about those? Okay. Imipenem, I often have to use combined with cystatin. Okay. Why do I have to use cystatin with imipenem? Because imipenem lowers your seizure threshold, and cystatin helps prevent the toxic metabolite from building up that lowers that seizure threshold. Okay, that makes sense? Carbapenems, big bad drugs for ESBLs. You do not use a carbapenem unless you absolutely have to, because when I start using a carbapenem, we're killing off bugs, right? And any bugs that live have the potential to now be carbapenem resistant. And now we're in a whole fucking world of hurt, okay? Carbapenem resistant bugs are increasing in prevalence. You got a question or? Yeah, imipenem plus cystatin. Okay, it helps kind of reduce the seizure risk in that drug. Carbapenems are nasty drugs, but you got to use them. Okay, there's that. Let's do a couple more. I'll just talk through this one. What if I have I don't know if you did my question of the day today, maybe you saw this, but this is a high yield question. You got a 40-year-old female, she's totally asymptomatic. For some reason, some idiot does a UA on her and a urine culture. Your UA has like 500 leukocyte esterase, 1+ nitrite. She's got white blood cells. She's got bacteria. You do a urine culture, it grows over 100,000 E. coli. She's asymptomatic. She's not pregnant, not doing any GU procedures. What do we do? Nothing. Absolutely nothing. If they are pregnant or if they are about to undergo a GU procedure, you treat them. Okay? Those are the guys. Everyone knows the pregnancy. They always forget or we're not taught the GU procedure. But it should just make sense, right? If I'm going in to their urinary tract and my urologist is messing around in the mucosa there, if they've got a brewing bacterial infection, we got to like stop that, right? So or at least mitigate it so that bacteria doesn't translocate and get out throughout the system. What are some of my options for just a run-of-the-mill cystitis? Bactrim, nitrofurantoin, phosphomycin is usually the other one. Those are the three I would know, okay? Nitrofurantoin for 5 days, TMP-SMX or Bactrim for 3 days, or phosphomycin for 1 day. Make sense? Levofloxacin can be used for, complicated cystitis. And then when we deal with pyelonephritis, okay, we got to give them IV, and it's usually, usually ceftriaxone is first line. That makes sense? Okay. What if you have a patient who's got tenosynovitis, dermatitis, and arthralgias, and they've got, let's say, they have risky sexual behavior, okay? I was trying to not like give it totally away, but risky sexual behavior, tenosynovitis, arthralgias, dermatitis. What is this? Disseminated gonococcal, okay? So let's say, how would you test for that? Yeah. Nat, where? Yeah. So we usually do they call it like triple point testing. We'll swab their pharynx, we'll swab their urethra, and then we can swab any other place that they might have had contact. So sometimes in the rectum or other areas, right? So we'll do the swabs of these other areas, and that's how we can see how they colonize with gonorrhea, right? If we have a concern for gonorrhea infection, and we've done a NAT, and it's just gonorrhea, what do we treat them with? Ceftriaxone, right? Okay, if we have not ruled out concomitant chlamydia, what else do we have to add? Doxy, right? So this is how they'll get you in the questions, is the patient will have like urethritis, right? So they'll have mucopurulent discharge from their urethra. They'll have a lot of pain down there. They'll make it pretty obvious. They'll have a high fever, and they'll say the NAT is pending or the gram stain is pending. You have to empirically treat them for both because we haven't ruled them out, okay? If we've ruled them out with the NAT, then I just need to do one or the other, either doxy or ceftriaxone, depending on which one. Gonorrhea can cause a lot of weird ass shit, right? So it's one of the big ones that can cause PID, okay, right? So upper genital infection in women, right? So the ovaries, the fallopian tubes tend to get impacted. That is right next to my peritoneal space, right? So the infection can ascend upwards. it can impact the liver, and you can get Fitzhugh-Curtis syndrome, right? Where you get hepatic abscesses and what are those violin strings. Gonorrhea can get disseminated, and it can actually cause super, super bad endocarditis. We didn't talk about it, but for Neisseria meningitidis, right, that can obviously get disseminated. You can get petechiae and purpura. You can get Waterhouse-Friderichsen syndrome, where you get hemorrhagic necroses of the adrenals as well. Okay, let me just see if there's anything else that's really worth talking, and then I'll let you guys run free. All right, what about septic arthritis? What do we know about that? Hmm? Were you thinking osteomyelitis for? Yep. Yep. So really, with a patient with bad septic arthritis, okay, their joint is going to be red, swollen, hot. They might have a fever, right? It gets tricky again when they have a prosthetic joint. You always have to ask about prosthetic joints, because again, that biofilm, it really will reduce your inflammatory response, and it will reduce the yield I get, right? So my cutoff for a prosthetic valve for WBCs is far lower. Okay, you have to have a high index of suspicion, but usually over 50,000 without a prosthetic valve. You have to be the way they'll ask it on a board question is they'll make you decide between, is this an infection or is this crystalline arthropathy, like a gout or a pseudo gout? If we do not know, you treat it as if it's an infection, right? So like a vancomycin plus a cefepime would be a great option, or vancomycin plus ceftriaxone would be great options for that. Osteo, the major cause is going to be Staph aureus. You got to consider salmonella in sickle cell. You got to consider Pseudomonas if you step on a nail through your shoe, right? That's the classic. Okay, let's do, what do you, for toxic shock syndrome, right? My two classic organisms are strep pyogenes, and then Staph aureus. Strep pyogenes is by far the more common one, right? This patient is going to be severely sick. They might have a maculopapular rash. They might have diarrhea, vomiting, right? They could have previous neck fash, right? So dusky leg, dusky arm, right? Pain out of proportion to exam, hemorrhagic bullae. So with this case, if it's toxic shock, how do I approach treating that? Obviously, go to surgery, right? Okay, what do we do? Not ceftriaxone could work if it's strep pyogenes. Yeah, I think that's pretty appropriate. What? Clindamycin is not controversial. Nope. Well, peds are stupid. I don't know what they're, because it does help. They've done study, and they're actually moving. So if it is strep and we know it, we don't have to use ceftriaxone. We can use penicillin. If we're not sure, and maybe this is MRSA, we can add Vanco. We can also put like ceftriaxone could be used. If you look at the IDSA guidelines for Infectious Disease Society of America, it's penicillin plus clindamycin for now. Yes. I don't, maybe on like pediatric it's different. I'm talking adult then. All my stuff is adult right now. I can show you the literature as well. So okay. Penicillin plus clinda. Penicillin is going to kill your strep. Obviously, Vanco would kill your MRSA. The clindamycin will inhibit your toxin production. And this is where maybe the controversy gets in, is we could use something like linezolid, which will do both. Linezolid would kill the bug and kill the toxin. So there's talks of moving towards linezolid monotherapy. Okay. We'll finish with, oh, this is okay. Bite wounds. Who do I treat a bite wound for? Or like which type of bite wound do I treat? Cat for sure. Human for sure. Dog maybe. Dog. So any bite near the joint space of the hands, in the genital or in the face, absolutely treat. Okay. Dogs, they've actually shown usually you don't get infected. Your right answer on a board exam is going to be treat them no matter what, right? But in real life, maybe you don't have to. Cats and humans, absolutely. The big one coming from cats and dogs is going to be like your Pasturella. Which one? Bartonella. Bartonella, if the cat scratches you, absolutely. Maybe a bite as well. Pasturella tends to be like the most common. Okay. From humans, you obviously can have strep viridians coming from the mouth. You can also have Eikenella, right? And then to treat them, right, a bite wound, amoxiclavulanate, okay? If they need to go to the hospital, ampicillin sulbactam, right, to give them IV. But amoxiclavulanate, again, like we've talked so many times, gram-positive, gram-negative, and anaerobe. That is going to be when you have a bite wound, all the things in my mouth, man, that's all this polymicrobial things going on. We'll cover it all. The piece I want to share with you is if the patient is asplenic, that's where we open up Pandora's box, right? So if my patient has no spleen, what are they really at risk for? Encapsulated bacteria, which would be strep pneumo, Neisseria, Haemophilus, Salmonella, right? Are the other big ones. So if they don't have a spleen and they start developing a fever, I need to cover for those, right? So ceftriaxone would be great to cover all of those. Okay. The key is though, if they are asplenic and they get bit by a dog and they get really sick, you got to think about one specific pathogen. I've asked about it on my questions of the day recently. Not Yersinia. Capnocytophagia canamorsis. Who's heard of that? So capnocytophagia canamorsis is a bacteria that's a gram-negative found in the dog's mouth. That when it's encapsulated. So when a dog bites you, normally your spleen can get rid of it. In a patient without a spleen, oh shit, that gets systemic real quick. It can cause purpura fulminans, which is going to be basically a DIC type picture, and the patient will become septic and die pretty quick if you don't catch it. So they like asking about a patient who doesn't have a spleen. They'll tell you they got in a car accident, X, Y, or Z. They get bit by a dog. You got to worry about capnocytophagia. You start piperacillin tazobactam, so Zosyn. Otherwise, if they have a spleen, start them on amoxicillin clavulanate, or if they get in a hospital, you do ampicillin sulbactam. Okay. Neutropenic fever, really quick. We got to cover for Pseudomonas. Okay. And my other gram-negative, so cefepime or Zosyn is a great first option. If they have a catheter in place, or they have a PIC in place, or they've recently been in the hospital, or they've had recent MRSA, you got to cover it for MRSA as well. Okay. But they will give you a patient who's a hemonc patient on chemotherapy. Their ANCs, like when we think about neutropenia, we think about a neutrophil count less than 1,500 is mild, and then less than 1,000 is moderate, less than 500 is severe. When that ANC is less than 500, I get really worried when my patient gets a fever. You want to empirically start cefepime or Zosyn or something that'll cover Pseudomonas. Does that make sense? If they have risk factors for MRSA, like we just talked about, start Vanco as well, but they don't always need Vanco. All right. And then my last thing I think I'll talk about, for any of these situations where they cause sepsis or septic shock, right? How do I define septic shock? SIRS. Yeah, we're moving away from SIRS. But yeah, SIRS. Yeah. So sepsis is an extreme inflammatory response, usually due to an infection. And then septic shock is a dysregulated inflammatory response, usually to an infection that is refractory to my job as a doctor to bring their blood pressure back and to quell this inflammatory state. Okay. So by definition, right, it's a mean arterial pressure less than 65. Okay. And then we've tried to give them fluids. We've tried to do other things to passively bring their mean arterial pressure back, and they're not responding. They now have end organ damage. That is septic shock. Okay. Mean arterial pressure. How do I calculate that? Other way. 2/3 diastolic plus 1/3 systolic, because we spend 2/3 of my cardiac cycle in diastole, passive filling. Okay. So if that mean arterial pressure is less than 65, they've got some sort of inflammatory response going on. You're like, oh shit, this might be septic shock. We give them, what do? What kind of fluid? Yeah, why not normal saline? Why? Something about chloride. So the guidelines say 30 cc's per kg of lactated ringers. And you as a medical student are just like, okay, yes, sir, do it, right? And you don't understand why. They've done studies on this, right? But when you look at the physiology, your normal saline, I don't know why they call it normal saline because it's not normal like physiologically at all. It's all over the place. You have 154 millimoles of sodium and 154 millimoles of chloride. What is my normal extracellular sodium in my patient? Yeah, 135 to 145-ish, right? So that's kind of close to 154. What's my normal chloride? Yeah, like 100, right? So that's like a huge chloride bolus compared to what we're normally getting, right? So I give them 30 cc's per kg of normal saline. I'm giving them a massive chloride bolus. What is the charge of chloride? Negative, right? What else is really important that's negatively charged in my body? Bicarb, right? Our body obeys the law of electrical neutrality. So if we're increasing chloride, your kidneys are like, well, see you later, bicarb, right? And it can cause a hyperchloremic metabolic acidosis. And I'm sure at some point in your first or second year, you did some stupid ass Anki card and you're like, yep, yeah, that makes sense, right? And no one understood it. The other problem is when you get elevated chloride, it can cause a transient renal vasoconstriction, which will only worsen, the state that they're in, where their vessels are really vasoplegic and we're not getting end organ perfusion, right? Lactated ringers has, usually about 28 millimoles of lactate or lactated bicarb. And so that lactate goes to the liver and gets converted to bicarb. And it can actually have somewhat of a small buffer effect as well. So lactated ringers is your gold standard for sepsis. We would get blood cultures, right? We would get lactic acid levels, right? If the lactic acid is above 2, that's another criteria for septic shock. We would then start empiric antibiotics, which we'll talk about in a second. And then if they are in septic shock, right, they're not responding to fluids, what do I start them on? Which one? Norepi, right? Norepi has alpha and beta agonism, right? So the alpha agonism will help constrict my vessels, increase that mean arterial pressure. The beta, it's got small beta agonism. It will help my heart pump a little bit more. Why don't we use epinephrine? We could use epinephrine. It's third line. Hopefully we don't get to that point. Correct, right? So epinephrine is really strong beta, not a strong alpha. It's not going to do exactly what I want. Kind of just like dobutamine, great beta 1 agonist, would be a shit drug to give in septic shock, right? Great for cardiogenic shock. Okay, so then if the patient has septic shock from literally any of the causes I go through here, it's septic shock secondary to pneumonia. It's septic shock secondary to an intra-abdominal abscess. Septic shock secondary to pyelonephritis. You would start that treatment, right? It's not rocket science. But some of your patients are going to come in. They're going to be in septic shock. You've done a very thorough history, physical exam, and you're like, I don't know where the fuck this sepsis came from, right? What do? You could call ID, but you better put them on something before you see ID. Otherwise, that patient's going to tank. Huh? Yeah, so what would your option be? Vancomycin plus, not ceftriaxone. Think about what do you got to cover? Correct. I like vancomycin plus either cefepime or Zosyn would be very fair to start. Okay. The problem with ceftriaxone, it doesn't cover Pseudomonas. Okay. So if they have septic shock of unknown origin, man, we got to cover broad and we got to cover the big bad things that I'm worried about. I need to cover MRSA and I need to cover Pseudomonas and my other GNRs. Okay. So vancomycin plus either cefepime or Zosyn are what are in the guidelines. If the patient has a past medical history, right, you go back in their chart, they have a past medical history of extended spectrum beta lactamases. I would do vancomycin plus carbapenem, right? Boom, done next. Boom. That's it. That's literally it. Okay. Then you do your workup, and then you call ID, and ID will tell you how to tailor antibiotics. Okay. I hate people don't be just relying on infectious disease, just like everything, right? Like a patient could have a new heart problem, right? If you're on internal medicine, you are an internist. You pass your boards, or you're a medical student who's on the team, right? You should be able to do at least the initial workup before running to the consultant. All right. Do you have any interest in talking about any of the other weird bugs that we haven't, or are we done? I can be done, and I can just talk about them if you have other questions. Okay. All right, then take a 5-minute break and we can do a quick discussion and then
I get it. Do anything good. She got her bag. 20-year-old girl. That's really funny. All over it.
And then take one for the.
In medicine, it's true.
Yeah.
I'm not getting real.
Like, how are they?
Gotta be a good-
How are they? Because I don't know how to.
That was trash. Like, where you go or inside. I think.
I have one of those.
It's like- it's very classy, it's very classy.
You just said it's trash.
No, two sides of the task.
I have one that is like there's always time for copying or something like that.
Yeah.
It's so silly. I got it. Yeah, I got it like obviously. Or no, I got it at like a couple dollars.
That makes sense. Oh, okay, yeah, and some of them are opening, should do anything less purple. I applied to UC. So they opened up on February 11th.
I just should.
Slice your finger.
So I applied there.
I thought you meant.
Slice your fingers.
Well, stuff.
You guys are good. Something these things. There you go.
See there?
That's so boring.
And no, she does like, yeah, and then she went to the ER.
No, I don't need candy.
Can you give it to me?
That's what I want to. I know I.
Yes, please. And then take some. Extra.
Yeah, and yeah, exactly. I don't want the ends off until I'm like a piece of like.
I just came for community service and I had to take a little part of the, I don't know if you know Thrive on, it's another MCW. And I
Alright,
actually
you figure it out. And then-
take a grab, just grab her handful. I'm just gonna remember the
Are
weekend
you on IM too?
in winter.
I am on.
Are you still on IM?
I'm not eating. Just
Oh, you finished already?
Yeah. That's quick, 4 weeks.
I think that's so stupid. 84 weeks is
Feel like the thing is big.
It is the
It's
biggest.
cover. Or the.
that's bad.
He was good.
The, but, yeah, it was the,
It was good.
fun, but yeah.
Oh.
I got the.
I like putting two.
I hated anesthesia. I thought
Really?
it was so boring.
Did they let you do stuff?
I got to intubate one patient the last day.
Dude, I intubated like 6 patients.
I know. I thought it was like, I didn't even get to put in a single IV either, so.
I'm glad they sent me to a small hospital.
Yeah, I was at the VA. And I thought the VA, they were supposed to let you do like a bunch of stuff and it was just, yeah.
You
Where
know,
are you at now? Like, what do you?
I just finished ID and now I start toxicology on Monday. I don't know.
We're able to do much on L&D as well, right?
Yeah, L&D was, I should start recording. L&D sucked. It was so bad. I hated it. Like even the people in my class who are like applying OBGYN hated L&D, or they hated like OBGYN in general. It's not people. So, yeah, after toxicology, I'm done. Then I have a vacation block and peace out of here. You get 2, so I took 1 last year before Scott. I'll do it in April, so. I like loved ID. I think that might be what I want to do. We'll have to see, but I say that about everything, so. But
That's the mindset you should have.
I don't, they just like their like way of thinking through problems. I was like, this is exactly how I think. And like, yeah. And we had one patient this last, like it was kind of like the weird patient we had that when we started. But she, 19-year-old, was like relatively healthy. She had a miscarriage back in August, and then slowly things like started kind of going downhill. And she presented with like just a lot of like your systemic wound problems. Like she had this weird cyclical fever, joint pain. She was like wasn't feeling herself. She had this maculopapular rash. She went to an outpatient Columbia St. Mary's, and they did like all of it, like all the ANAs, all your antibodies, and everything came back negative. So the only thing that was positive was like really low titer SSA and a very, very low titer Bianca. And they were like, we don't know what this is. It might be, they said like adult onset stills versus like typical lupus. So they treated her with steroids and plaquenil, hydroxychloroquine, sent her home. She followed up and was like, I'm still not getting better. And then a week after that, she started like developing acute psychosis. Like she was like all over the place. So her parents brought her in and afraid her because like, didn't do it. And so she's been at our hospital for over a week. And they found, I mean, her liver enzymes are pretty elevated. They got a chest CT that shows ground glass opacities. They got a TTE. She's got new like left ventricular heart failure. Her kidney started failing, so they did a kidney biopsy that showed collapsing FSGS. And then they eventually like consulted us. Like she was at the hospital for like 5 days. They consulted us and they were like, we don't think it's infectious, but like, please rule something out. And I'm like, okay. Like I talked to her that first day, she wouldn't even talk to me. She was like so psychotic. She like, you're the one that cut my hair and like put these wires in my brain. I'm like, no. So we just kind of let her go. And like I looked back at her chart and she was like, her white blood cell count would go down and then up, down and up. And I was like, maybe is this like cyclical neutropenia? But like neutrophils are normal, but it was like primarily like lymphopenia. And so I'm like, okay, if I'm putting this together, she has like a new undiagnosed like wound problem. And I'm thinking lymphopenia, like viral would make sense. So I had him send like EBV, CMV, parvo, which are the big ones associated with FSGS. They already got HIV was negative, syphilis, hepatitis were all negative. And all those came back negative. And I went in the next day and she was then like, she talked to me and her grandma and mom were there. And so I asked her like all the fun ID questions, like, where'd you come from? Where'd you go? What do you do? Pets and stuff. And she had a kitten. She has dogs, and I was like, had a kitten. They're like, yeah, we got rid of it. But like, they got the kitten after she started having the symptoms. But the mom said like her symptoms flared when they got the cat. Okay, like ever been scratched by it? She's like, yeah. And so I was like, you know, I wrote in my note, I'm like, this is really low yield, but I would consider getting like cat scratch antibodies for Bartonella, because Bartonella causes a lot of weird shit. It causes neuroretinitis, encephalitis, transverse myelitis. It can cause endocarditis and cardiomyopathy. Yeah, cause transaminitis. I'm like, it honestly would explain a lot. It wouldn't explain the rash. It wouldn't explain some of our other like the FSGS. It wouldn't explain. But I'm like, sure, why the fuck not? But we have like no answer on her. They want to get a cardiac MRI. I think they want to get a lung biopsy, but like all of her tests have come back negative. Room kept getting like antibodies, and they one of the ANAs finally came back positive. And I think I'm like, at this point, like, can you even consider it positive if you have to check it like 5 times? So I don't. It sounds like they're just going to start her on steroids. Yeah, see what happens. But they did like Columbia St. Mary's, but since she's been here, they haven't. Like your big concern is if this is infectious and you start a steroid, you're going to mask it and it's going to get worse. And they didn't want to like the other big thing you got to consider like for board exams like this. If you're considering cancer or other things, if you give steroids, it can reduce your yield on getting the times. So
I got kind of frustrated on that's one person surgery because it feels like they don't really care if guys use something or something out. It's like I get it, you don't want to chase things if like
no, just yeah, no.
And like this person had like unexpected like you're reading and we're just like everyone needs just eating right now. So
I'm telling you, ID, you'll like ID. All right, let's talk. We'll talk about some of these really quick. Oh yeah, I'll go through them relatively quick. If there's one that you want me to talk about that I don't talk about, let me know. What do we know about PJP? Who's my patient? HIV, and then patients on long-standing steroids, right? The classic example is a patient who's on 20 milligrams or more of prednisone or prednisone equivalent for longer than 4 weeks, 28 days. Those are the patients who need to be on PJP prophylaxis. So they'll tell you they have a history of sarcoidosis or they'll have a history of lupus. They've been on long-standing prednisone, never been put on prophylaxis. That's your patient you want to consider PJP. And then obviously HIV. How does HIV, what is acute retroviral syndrome? How does that present? Yeah, it's mono. It's mono with maybe a rash, maybe diarrhea, pharyngitis, splenomegaly, hepatomegaly, macular papillary rash, diarrhea, all your monotype symptoms. So they might like preclude to that, and then a couple weeks later they get PJP pneumonia, right? So this is going to be a very, very, very severe presentation of pneumonia. They're going to be extremely sick. You're going to see bilateral infiltrates as the classic. Their LDH is going to be sky high because all these cells are getting lysed. Their beta D glucan might be elevated as well from the fungal cell wall. Okay, how do I treat? TMP SMX. And then if their PaO2 is low, if it's less than 70, we give dexamethasone as well. Okay. And then again, the prophylaxis is going to be TMP SMX, right? They'll ask you that as well. We start prophylaxis when the CD4 count is less than 200. I think that's what I wanted to say. Yep. Okay. Makes sense. So the question they'll get you on is the PaO2 will be less than 70, and they'll ask you what else should we start, and you're not going to see TMP SMX as an answer. You're going to pick dexamethasone, right? Because that has been proven to help when it gets that low. So if you have PJP pneumonia and the PaO2 is less than 70, we start dexamethasone. It improves mortality. It improves time in the hospital. Yes. No. What? Chloroquine? You're thinking of toxo. We can use pyrimethamine and sulfatazine. Yeah. So treatment for PJP is TMP SMX. Absolutely. Okay. Dexamethasone. I don't know what you're thinking of. Okay. TB, are we good on TB? Treatment for TB? Okay, that one you guys should know. Let's see. Toxo. Who gets toxo? Everyone gets toxo, right? All of us probably have toxo, maybe from eating uncooked pork or like undercooked meat or poultry, or being around cats or litter box. So toxo is a disease of reactivation, right? So I often see like doctors will order like toxo IgG, and like that doesn't tell me anything, right? Because like almost everyone here would be IgG positive. All that tells me is if their IgG is positive and they've got a clinical syndrome consistent with toxo, maybe it's toxo, right? So who gets toxo are going to be immunosuppressed, right? Really bad HIV, usually when the CD4 is less than 100. So toxo again can present with a mononucleosis type syndrome. And then what are the really bad toxos? Like what is it? What do I get really scared about? Torch, yes. Cerebral, absolutely. So Ringing-Hansen lesion, usually multiple Ringing-Hansen lesion. They'll ask you like they'll show you it'll be a patient with really bad HIV and they'll have multiple Ringing-Hansen lesions. You want to think about toxo. If it's one, maybe more primary CNS lymphoma, which is a B-cell lymphoma, often due to EBV. And then toxo in the eyes, retinitis is the other classic presentation. So that is going to be your pyrimethamine and sulfatazine. And then you want to add leucorvarin, which is B6, right? Because we want to add the B6 because these molecules, sulfatazine, is going to block B6 from being used. So we got to add in extra B6 to make sure they don't become deficient. CMV, we've already kind of talked about. CMV, again, really bad HIV, like CD4 counts less than 50. You can get the retinitis, esophagitis, colitis. So it's classically a bloody colitis, right? And then again, what's the treatment for CMV? Ganciclovir, valganciclovir, right? So your acyclovir and valacyclovir don't work for CMV as well, okay? And vice versa. If for some reason they can't get valganciclovir or ganciclovir, what's my second option? Cidofovir or foscarnet, okay? All right, though sometimes they ask. EBV can cause everything and anything, right? Mono, of course. CMV and toxo can also cause a monotype presentation. EBV can cause Burkitt's lymphoma. So we see a massive tumor on the jaw or in the belly. EBV can cause that primary CNS lymphoma. It's implicated with a lot of the other different causes of lymphoma as well. We've already kind of talked about how that presents. You see massive splenomegaly. How do I treat it? Supportive, right? Supportive care. For obviously, if it's cancer, we got to treat the cancer. But if it's just mono, supportive, you got to be careful on that spleen. Usually 3 to 4 weeks without contact sports, so we don't get splenic rupture. Okay. Let's talk about blasto. Who gets blasto? Immunocompetent, immunocompromised? Everyone can get blasto, right? Blasto does not give a fuck, right? Histo and coccidio tend to cause your disseminated presentations in the immunocompromised. Blasto can absolutely cause disseminated infection in immunocompetent, okay? It's a big bad bug. When you think about these blasto, histo, coccidio, right? These endemic fungi, you're classically taught like blasto. What are you taught about blasto? What's the like buzzword? Broad-based running, but like where's it found? So it's usually like the Ohio River Valley is histo, and you know, like your Mississippi River Valley is more blasto, but like, huh? Huh? Correct. Yeah. So your blasto, I tend to think about it as Midwest, and then it can even move off Eastern and Southern. Histo, again, more or less same thing. It likes the Ohio River Valley, Mississippi. The thing though, and then coccidio is going to be more Arizona, Mexico, California, Texas. The problem is with now all this global warming and climate change, they don't give a fuck anymore. Things are moving around, so you can get a patient with histo coming from like Oregon, right? Like that you shouldn't see. So yes, taking a really good travel history and where they're from can help, but now kind of things are, it's like wide open, right? Histo, I also say, is found very prominent in like South Central America, like Peru. It's really found. There are cases in Brazil, Ecuador. So those are things to consider as well. So blasto tends to be immunocompetent or immunocompromised. Classically a pneumonia type picture. And then what's its disseminated picture? How do you visualize a patient with disseminated blasto? What you got? Okay. Yeah. Did you guys?
See the picture.
Yeah.
Okay.
They're called verrucous lesions. You can just look them up online. I can't describe those. They're big and nasty. Blasto also loves the bones. Okay, so it can cause osteo. It loves the prostate in men, and then it loves causing meningitis as well. Okay, so a patient with big bad blasto, okay, they have to be hospitalized. What do I treat them with? Amphotericin, right? Amphotericin usually for 2 weeks. Take them off. Put them on itraconazole. This is usually the long-standing term. What do I have to worry about with amphotericin? Yeah, really bad for the kidneys and your electrolytes, right? So got to watch that. Histo, right? Again, a pneumonia, but then it gets disseminated in immunocompromised patients. So where does histo live? Like where? Which cells? Macrophages, right? The reticuloendothelial cell system. So macrophages, liver, spleen are the big spots, okay? It also can get into the bone marrow and cause cytopenias. It can cause oral ulcers. It can cause erythema nodosum. And then a big old spleen, a big old liver, and those can start to fail as well, right? Coccidio in immunocompetent can cause what's called valley fever. So that's like it's kind of like Pontiac fever, like we talked about, like a mild, fever, maybe a low-grade pneumonia. When it gets bad, right, it can get disseminated again. You can get meningitis. You can get arthralgias, erythema nodosum, uveitis. The erythema nodosum in these guys is actually a good sign. It tells me we're mounting a Th1 response, okay? So we actually like to, when I see the erythema nodosum, it's actually a good sign. It means they're fighting off the infection. For all of these, again, Ampho B, if they're sick enough to really be in the hospital, and then an azole, like itraconazole, is if outpatient or for multiple months after. Does that make sense? Great. What do we know about Babesia? Ticks, Ixodes ticks, right? The Maltese cross. You're rarely going to see them, but if they want you to think about Babesia on an exam, they'll give you the Maltese cross. Okay. Where do I get Babesia from? America, yeah. So Midwest and Northeast, okay. It's the same tick that disseminates Lyme and ehrlichiosis, right? So when I think about Babesia, it's an intraerythrocytic parasite, right? So often when I see on my blood smear, I see something in my red blood cells that shouldn't be there. My differential is usually pretty low. I think about Babesia and I think about malaria, right? A good travel history and a job history will tell me everything I need, right? If you haven't traveled outside the country, very rarely would this be malaria. If this patient hasn't traveled outside the country, when would I actually consider a malaria diagnosis? They might show up very similarly. We'll talk in a second. And the patient tells you, I've never left the country. Neither has any of my family. But I'm like, this guy has malaria. No. So maybe the thing you want to consider is where does the patient work? If they work at an international airport and you got all those baggages, there have been several case studies on that. Would that ever show up on a USMLE question? Absolutely not. Kind of, yeah. But it's something you want to consider. But so really, right, if they've never traveled outside the country, they tell you that on an exam, and they're from Connecticut, it's babesia. So with that, right, you're going to have high fevers. You're going to have, if they have a spleen, you'll get splenomegaly. You'll get hemolytic anemia, right? So low hemoglobin, elevated LDH, low haptoglobin. The reticulocyte counts, as long as the bone marrow is fine, should be elevated. I already said high fevers. So that's what you're going to see, right? We'll do a peripheral smear, and we can diagnose babesia that way. What's my go-to treatment for, we'll call it non-severe malaria or babesia? No, it's a parasite. Atovaquone plus azithromycin. Atovaquone plus azithromycin. On a very important exam that I shall not name, that I may have taken a year ago, there was a question where they gave you the run-of-the-mill Maltese cross, and they asked, which of the following should be used for treatment? And there was like 20 options, and they were all nonsense. And I'm like, no one is going to know this except for this guy right here. And the answer was azithromycin. And I'm like, no one knows it, right? If it's really severe, you could potentially use a quinidine plus clindamycin. That's like kind of falling out of favor because quinine has a lot of side effects. If their parasitemia is above 10%, there is data to use plasmapheresis as well. They will not expect you to know that. I want you to know atovaquone plus azithro. You'll remove the red blood cells. Yeah. Well, plasmapheresis, red blood cell exchange, whatever you want to call it. Like you're going to remove the red blood cells. Okay. Okay. Since we talked about the ixodes, ehrlichiosis is going to present more or less similar. It likes to impact the neutrophils, not your red blood cells. And again, like ehrlichiosis tends to be more like southeastern, south central America. So like think your Mississippi, Arkansas, Louisiana, that type of area. I do want to spend a second on Lyme disease because again, the same ixodes and Lyme disease you will get a question on, and you're in Wisconsin, you're going to see a patient with Lyme disease at some point. So Lyme, right? We have multiple stages, right? Primary, we usually see the erythema chronicum migrans, the bullseye rash. As we progress, we can see joint pain, right? What's the classic, if we're going to get arthritis, what's the classic arthritis? It's in the knee. Is it both knees, one knee? Usually one knee, and it looks like a freaking watermelon or a basketball, okay? As Lyme progresses, right, you can get conduction blocks. You can even get cardiomyopathy, and then you can get meningitis, encephalitis. So what's the outpatient treatment for Lyme? Doxycycline. Okay, if they're a pregnant woman, what do we give them? You could maybe use azithro. I like amoxicillin or cefuroxime a little bit better. Then what? Amoxicillin has better like coverage for Lyme than azithro. If they are requiring, if they have a heart or neuro manifestations, they got to go to the hospital. And what do we treat them with? Ceftriaxone, right? So this is how they'll get you, is it's going to be Lyme, or they're going to tell you patient is from Vermont, and now they've got the rash and the joint pain, and then they'll tell you the patient had a syncopal event. They'll show you an EKG, and it's like 3rd-degree heart block. And they'll say the patient's admitted to the hospital. What do you want to do next? And they'll say pacemaker, atropine, ceftriaxone, doxycycline, steroids or something. People will either pick the pacemaker or they'll pick the doxycycline. If you have to get admitted to the hospital for Lyme disease, brain or heart, you got to do ceftriaxone. You need a big gun. Can't use doxy. All right. We're good on Lyme. Lyme, I'll tell you, Lyme disease, TB, and syphilis, I call them like the great imitators, right? They can do a lot of really weird stuff. So if you're at like a wit's end, you might want to consider working them up for one of those, okay? All right, there's Babesia. Malaria, again, malaria is going to be more or less a very similar picture to Babesia. The thing I should say about Babesia, Babesia gets really bad if you don't have a spleen, okay? The spleen helps remove those infected red blood cells. So in the vignette, they'll give you a patient who has asplenia if they want you to get at Babesia. Malaria doesn't care if you have a spleen or not. It's that bad. Again, really high fevers. We got to think about my Plasmodium falciparum versus my Plasmodium vivax versus ovale, right? Very, very different in ways we treat them, right? Falciparum is now essentially chloroquine resistant, okay? Like chloroquines ain't going to work on them, okay? Again, it kind of depends on where the patient is coming from, but for the most part, like falciparum, we've exhausted like chloroquines. So what do we do for falciparum? That's good for prophylaxis. Maybe if it's bad. So atovaquone progranol, I'll put as like a second line. We can use artemether and lumifrestin. It's the brand name is Coartem, Coartem. Just look it up because I can't pronounce these drugs for shit. So make sure you know that one because that is now first line and it's been first line for a couple years. So that's fair game. If they have Vivax or Ovale, remember those can form schizonts that live in the liver and they just sit there, right? Any of these drugs that we've talked about, atovaquone progranol or Coartem, they don't touch the schizonts. So what do I have to add on top of that? Not chloroquine. Well, yeah, it's a type of chloroquine. Which type? Primaquine, right? So primaquine. So they will give you a patient who's had malaria. We've treated them appropriately, right? And they're still not getting better. They're still cyclical fevers. Maybe they'll tell you their liver's elevated, or they'll be nice and they'll tell you it was Vivax or Avale, and they'll say, "What should we do?" And you add primaquine. Okay, that's malaria. Just a few more. Leptospirosis. Who gets leptospirosis? Yeah, water sports, right? So you got to be around infected water, right? What do I mean by infected water? Usually rodents or other small little animals pee into the water source, and then you as the human come in contact, and it either gets into your eyes, your ears, your mouth, other cracks and crevices, right? And so, yes. Usually fresh water, yes. There have been cases, though, where like there's a case, I was reading a case report on a man who, it was in the middle of like winter, and he had rodents in his attic, and he was like picking up something that he ended up getting, he never came in contact with the rodent, but he picked something up, moved it around, and then he ended up getting leptospirosis. And so the thought was that the rat peed on whatever he grabbed, he touched it, and then probably touched his eyes or something. Your classic, if they want to give you on step, it's going to be someone in Hawaii who just went surfing, right? Hawaii, in America, Hawaii is like where you'll find it, but any of the coasts really, and any patient in contact with rats, squirrels, things like that, especially rodents. Huh? Is it? I'll have to double check on the salt versus fresh water. Yeah. Okay, there you go. All right, learn something every day. What I want you to get at, right? So the patient's going to have some exposure to a rodent or water sports, and then how does it present? Right? Sometimes it will be asymptomatic if you're healthy, but when it presents severe, how does it present? There's a few classical findings. Yeah, so it's called conjunctival suffusion, where look up a picture of it, because I can't do justice describing it. Their eyes are really red and really beefy. Leptospirosis can then progress to what's called Wheels disease or Wheels syndrome, where you can get kidney and liver failure. It can also cause weird things like thrombocytopenia, anemia, lymphopenia, like that, right? So if they have the right history, think about it. Leptospirosis is a spirochete, just like our good friend syphilis, right? So we can treat it more or less the same, right? A penicillin or a ceftriaxone would be good. Whenever I'm dealing with a spirochete, we got to worry about what? Yeah, Herxmeyer reaction, right? So when I give them the beta-lactam, we're going to lyse all these cells. We're going to have a massive inflammatory response. they're going to spike a fever, maybe have a little bit of a headache. We just stay the course. Okay, stay the course. That's leptospirosis. Let's do like one or two more. I just talked to them about Bartonella. Bartonella is like one of my favorites. When do we think about Bartonella? There's multiple types. Cat scratch, right? Bartonella hensley is a classic culprit of cat scratch disease, right? It can be scratch, it can be bite. Any contact with cats, really, the scratch or bite is really going to get it into the bloodstream. So how does just run-of-the-mill cat scratch disease present? Yeah, you could leave it alone. It's usually at the inoculum site, you get a big old papular vesicular lesion. You usually get lymphadenitis and lymphangitis that can then ascend up. So like they might get bitten maybe like up on the hand or the shoulder, and then they end up one of the lymph nodes up here on the same track of the body ends up getting infected. But you more or less, it's usually around the site, okay? And then Bartonella can do a lot of weird shit, okay? So Bartonella is another one, maybe I'll put into the great imitator, where it can do a lot of weird stuff. It can cause neuroretinitis, so the patient is starting to lose their vision and they have ophthalmoplegia, so they can't move their eyes as much. It can cause encephalitis, encephalopathy, transverse myelitis, endocarditis. Let's see what else. Transaminitis. It can impact the kidney. I mean, it can impact really everything, right? So it's one of those weird ones. If they're going to ask it on a board exam, it's going to be the classic, exposure with the papular lesion with lymphangitis, and then maybe it progresses to culture negative endocarditis. It's one of the classic culprits. But be on the lookout for the neuroretinitis, the encephalitis, and things along those lines. Remember, like your culture negative endocarditis are classically your Hayseck organisms. So that's Haemophilus. It is Agrotobacter, Cardiobacterium, Eikenella, and Kingella. Okay, so those are my 5 gram negatives, my Haysecks. And then it's also my Coxiella. So that's a patient that can cause Q fever. They need to be around in that case. The classic exposure is amniotic fluid of farm animals, right? So sheep, farm, like goats. You might see that in Wisconsin, right? Bartonella, and then brucellosis is another one. Brucellosis is a weird one. Brucellosis you have to get usually from unpasteurized dairy products, and it's quite common in like the Middle East. So I think with that, that one can cause your cyclical fevers, your arthralgias, osteoarthritis. For a cat scratch and brucellosis, doxycycline tends to be a great option. And let me just make sure I'm not missing anything. Yeah, and then for brucellosis, we tend to use rifampin as well. But doxy or azethro tend to be like the backbone for both of those. What else? Is there one that I didn't talk about that you want me to talk about? Tularemia, rabbit fever, right? Get bit by a rabbit, or they're a hunter or deer or shit like that. Tularemia, again, can cause whatever the fuck it wants. It can cause a pneumonia. It can cause an ulceroglandular lesion, right? And that one, it's a gram negative. So like something like ceftriaxone or Zosyn tend to be a good first line. What else? Did I not talk about one that you want me to? Some weird one. Okay. We're good? All right. Bugs and drugs. Really? Take a step back. Who is my host? What is my clinical syndrome? Where does that interact? And then just think. I don't need you memorizing. Okay, it's this. I need to use these drugs, right? The more you do it, the better you get, right? Like I've treated in my 2 years in the hospital, I've treated enough pneumonias that I can recite to you, the regimen, right? But it's understanding, like using pneumonia as the example again, because that is the most common infection that you're probably going to see. Understanding I need to cover these bacteria that are typical and these bacteria that are atypical. And so here are options that would work for both of them, right? Step 2 still asks a lot of pathophysiology questions. So it's very fair for them on a question. You'll be expecting it to say, like, for pneumonia, like ceftriaxone plus azethro, but instead it's going to describe like the mechanisms of the drugs, right? Like blocking the penicillin binding and then blocking the 50S ribosome, right? So just be on the lookout for that. Like I promise you, there was I went in knowing there was going to be a lot of pathophys, and I like made sure I knew it. And there's on my exam, I'm like, there's a lot more like pathophys straight up like step 1 style questions than I thought. What there won't be there shouldn't be like which chromosome is impacted or which what's the genetic inheritance of it. Like those are like leave those shit in step 1 land. But there will be like questions on pathophys. So bugs and drugs, all the shit is in here. I obviously can't cover everything, but like, hey, if you're on the wards and you're like, I don't know what to do, you look at the PowerPoint, type it into open evidence. I use what's called Sanford. If you've ever heard of like the Sanford antimicrobial guide, it costs money. But like if you're going into internal med or family med or even the ED, I think would be a good one too. And you're treating infections every day. The Sanford is updated daily, and it gives you syndromes, pathogens, etc. You can literally look up almost everything. They give you, it's updated like so frequently on regimens, and then it gives you like a beautiful like 1-page summary of everything you need to do, and it links case reports, clinical trials, etc. So you can go read the primary literature. It's like $80, but you can get a discount. So I think it's like 40 or 50 as like a student. That's one of the ways I help use this. And then what I do, this is one way, and then we'll be done. Just like I've taught you for everything, like on the wards, let's say you have a patient with pneumonia or endocarditis, take a step back and be like, I think it's caused by this bug. I want to start them on this and this. Then go into Sanford and see if you were right. Go into open evidence and see you're right. Don't just like jump to it. Okay, if you have no idea, then jump to it, but like test yourself and see. Okay. I'll stay after for a couple minutes and answer questions. I plan on hosting maybe like 1 or 2 like general step 2, not just bugs and drugs, before I leave for residency. So, all right, we'll leave it on that. Yep. That's when you would use, yeah.